The thigh is the part of the lower limb located between the hip and the knee, and it can be divided into anterior, medial, and posterior compartments that surround the femur. These compartments are formed by the intermuscular septa that originate on the inner surface of the fascia lata and attach to the linea aspera of the femur. And, more importantly, each compartment contains its own muscles, as well as blood vessels and nerves. Each muscle in the three compartments has a proximal origin and a distal insertion, a neurovascular supply, and a specific action on the joints of the lower limb. So, the anterior compartment, which is the largest one, includes the anterior thigh muscles, which can function as flexors of the hip and extensors of the knee. First, the flexors of the hip include the pectineus, iliopsoas, and sartorius. The pectineus is an almost rectangular muscle located in the anterior part of the superomedial portion of the thigh, and it's often composed of a superficial and deep layer. It originates on the superior ramus of the pubis and inserts on the pectineal line of the femur, just inferior to the lesser trochanter. Now, this muscle has a lot of nerve, mainly because of its dual nerve supply. One supply is from the femoral nerve, and the second supply is from a branch of the obturator nerve. Finally, the pectineus has three main actions. It adducts, flexes, and medially rotates the thigh. This is one muscle, two nerves, and three actions. Second, the iliopsoas is the most powerful of the hip flexors. It has most of its mass located in the posterior wall of the abdomen and greater pelvis. Actually, it consists of two parts. Its broad lateral part is called the iliacus muscle, which arises from the floor of the iliac fossa, ala of the sacrum, inner lip of the iliac crest, and anterior sacroiliac ligaments. And its long medial part is called the psoas major. It originates from the sides of the T12 to L5 vertebrae and the discs between them, as well as the transverse processes of all lumbar vertebrae. Sometimes there's another component, called the psoas minor, which originates along the sides of T12 and L1 vertebrae and intervertebral discs, and attaches distally to the pectineal line and iliopectineal eminence. Okay, so the iliacus and psoas major merge distally at the level of the inguinal ligament to form the iliopsoas, which crosses the hip joint to insert on the lesser trochanter of the femur. Regarding innervation, the iliacus is supplied by the femoral nerve, while the psoas major is supplied by the anterior rami of L1 to L3. Now, given the fact that the iliopsoas is the only muscle attached to the vertebral column, pelvis, and femur, it's easy to understand why it is the chief flexor of the thigh at the hip joint, and one of the flexors of the lumbar part of the vertebral column. The iliopsoas is also a postural muscle and stabilizer, and it's active especially during standing when it helps maintain normal lumbar lordosis or curvature of the lumbar spine. And third, the sartorius, or the tailor's muscle, name given by the fact tailors would sit in a cross-legged position while sewing, which mimics the action of the muscle. It's a long and ribbon-like muscle situated superficially in the anterior compartment, and within its own relatively well-defined fascial sheath. It originates on the anterior superior iliac spine, and the superior part of the notch underneath it. From this point, it crosses the anterior thigh diagonally from lateral to medial, moving distally to the medial side of the knee, and it inserts on the superior part of the medial surface of the tibia. Regarding innervation, it has the same nerve supply as the iliacus, which is the femoral nerve. Now, its attachments make the sartorius the longest muscle in the body and allow it to flex both the hip and the knee joints. It also weakly abducts the thigh and rotates it laterally. And when both sartorius muscles work together, they bring the lower limbs into the cross-legged sitting position. Okay, now when it comes to extensors of the knee, we're actually only talking about the quadriceps femoris muscle, which, in turn, has four components. The three vasti muscles, vastus lateralis, vastus intermedius, and vastus medialis, so named by their position around the femoral shaft, and the rectus femoris. Together, the four components form the largest and one of the most powerful muscles of the body, which acts on both the hip and knee joint. Now, let's go through these one by one. The vastus lateralis is the largest of the four components. It lies on the lateral side of the thigh and originates on the greater trochanter and lateral lip of the linea aspera of the femur. Vastus medialis covers the medial side of the thigh and originates on the intertrochanteric line and medial lip of the linea aspera. Vastus intermedius lies between the vastus medialis and vastus lateralis and originates on the anterior and lateral surfaces of the shaft of the femur. And finally, rectus femoris lies on top of vastus intermedius, and it received its name because it runs straight down the thigh, rectus meaning straight in Latin. The muscle originates on the anterior inferior iliac spine and the ilium, just superior to the acetabulum. Because there's power in unity, all tendons of the four parts of the quadriceps unite in the distal portion of the thigh to form the quadriceps tendon. Moving distally, the quadriceps tendon envelops the patella and continues as a patellar ligament, which crosses the knee joint and attaches to the tibial tuberosity. The transition between the quadriceps tendon and patellar ligament is marked by the patella, which is embedded within it, making it the largest sesamoid bone in the body. The medial and lateral vasti muscles also attach independently to the patella and form aponeuroses called the medial and lateral patellar retinacula. The retinacula reinforce the joint capsule of the knee joint on each side of the patella en route to attachment to the anterior border of the tibial plateau. The retinacula also play a role in keeping the patella aligned over the patellar surface of the femur. The quadriceps femoris is supplied by the femoral nerve. All in all, the components of the quadricep muscle help extend the leg at the knee joint, especially against gravity. This action is important when rising from sitting or squatting, during climbing and walking upstairs, and running and jumping. At the hip, it aids in hip flexion through the action of rectus femoris, as it is the only portion of the quadriceps that crosses the hip joint. Additionally, the quadriceps is primarily responsible for absorbing the shock of heel strike, which is when the foot touches the ground heel first during walking or running. And it functions as a hip fixator or stabilizer during bent knee sports, such as skiing and tennis. Now, that was a muscle fatigue-inducing load of information. Let's take a break and see if you can recall the origins and insertions of the anterior thigh muscles. Now, let's talk about the muscles of the medial compartment of the thigh, which form the adductor group. This group is made up of 5 muscles: adductor magnus, adductor brevis, adductor longus, gracilis, and obturator externus. These function together to adduct the thigh and stabilize the stance when standing on both feet, or during side-to-side movement while standing. First, adductor magnus is the largest, most powerful, and most posterior muscle in the adductor group. It's a triangular muscle with the tip towards the pubic bone and a thick medial base. The base is divided into 2 parts. The superior segment is called the adductor part, and it originates on the inferior rami of the pubis and ischium. And then it fans out widely for an aponeurotic attachment to the gluteal tuberosity, entire length of linea aspera, and medial supracondylar line of the femur. The inferior segment is called the hamstring part, and it originates on the ischial tuberosity and attaches to the adductor tubercle of the femur. Regarding innervation, the adductor part is supplied by the posterior division of the obturator nerve, while the hamstring part is supplied by the tibial division of the sciatic nerve. The adductor portion adducts and flexes the thigh, where the hamstring portion extends the thigh. Second, adductor brevis, or the short adductor, lies underneath the pectineus and adductor longus, where it arises from the body and inferior ramus of the pubis. As it travels distally, the muscle widens to attach to the pectineal line and proximal part of the linea aspera. When the obturator nerve emerges from the obturator canal to innervate muscles in the medial compartment, it divides into an anterior and posterior division, with these two divisions passing anterior and posterior to the adductor brevis. In doing so, the obturator nerve and branches of its anterior division innervate the adductor brevis. While this pattern of the anterior and posterior divisions sandwiching the adductor brevis is a useful tool to identify the adductor brevis on dissection and cross-sectional imaging. The main action of the adductor brevis is to adduct the thigh. Third, adductor longus, or the long adductor, is a large triangular muscle that arises from the body of the pubis, just inferior to the pubic crest, where the apex of the triangle is. It then moves on to attach to the middle third of the linea aspera of the femur, where the base of the triangle is. In doing so, it covers the anterior aspects of the adductor brevis and the middle of the adductor magnus. It's also supplied by the obturator nerve and branches of its anterior division, and its main action is to adduct the thigh. Fourth, gracilis, meaning slender in Latin, is a long, strap-like muscle situated medially and superficially. Now, the muscle originates on the body and inferior ramus of the pubis, but its insertion on the superior part of the medial surface on the tibia is a bit more complicated. This is because gracilis joins the sartorius and semitendinosus, a muscle of the posterior compartment, to form a common tendinous insertion called the pes anserinus, or the goose's foot, because it resembles, a goose's foot. Pes anserinus goes and inserts on the superior part of the medial surface of the tibia, and you can actually use the mnemonic say grace before T to remember the order of their insertion on the tibia. Sartorius is the most anterior of the muscles, followed by gracilis, and then by the semitendinosus, which is the most posterior muscle of the pes anserinus. And finally, gracilis is supplied by the obturator nerve and acts to adduct, flex, and medially rotate the thigh, as well as add stability to the medial aspect of the knee in extension. And fifth, the obturator externus is a flat, relatively small, fan-shaped muscle that is deeply placed in the superomedial part of the thigh. It extends from the external surface of the obturator membrane and the margins of the obturator foramen to the trochanteric fossa of the femur, passing directly underneath the acetabulum and neck of the femur. It is supplied by the obturator nerve and helps to laterally rotate the thigh and steady the head of the femur in the acetabulum. Whew, that was a very longest section that could have been more brevis. Let's relax for a bit and try and recall the origins and insertions of the medial thigh muscles. Now, before we move on to the other components, let's talk a bit about the particularities of the anterior and medial compartments. First, the femoral triangle, distal to the inguinal ligament, helps to understand structural relationships in the groin, and it's a useful landmark in dissection. It's bounded superiorly, where the base of the triangle is, by the inguinal ligament, medially by the lateral border of the adductor longus, and laterally by the medial border of the sartorius, whose medial border, together with the lateral border of the adductor longus, forms the downward-looking tip of the femoral triangle. Moving on, the muscular floor of the femoral triangle is formed by the iliopsoas laterally and the pectineus medially. The roof, on the other hand, is formed by the fascia lata and cribriform fascia, subcutaneous tissue, and skin. There's also a lot of stuff in the femoral triangle, which you can remember by using the navel mnemonic. From lateral to medial, navel stands for femoral nerve and its terminal branches, the femoral artery and several of its branches, femoral vein and its proximal tributaries, the empty space where the femoral canal is, and the deep inguinal lymph nodes and associated lymphatic vessels. Another important element within the femoral triangle is the femoral sheath, which is a funnel-shaped fascial tube that houses the proximal parts of the femoral artery, vein, and deep inguinal lymph nodes. The tube is formed behind the inguinal ligament by a downward extension of the transversalis fascia anteriorly and iliopsoas fascia posteriorly. The sheath terminates inferiorly by blending with the outer layer of the femoral vessels, and its purpose is to allow the femoral vessels to glide deep to the inguinal ligament during hip movement. Particular interest is usually given to the femoral canal, which lies in the femoral sheath between the medial edge of the sheath and the femoral vein laterally. The conical canal starts at the inguinal ligament and it extends distally to the proximal edge of the saphenous opening. And just in case you forgot, the saphenous opening is an oval opening in the upper mid part of the fascia lata of the thigh, covered by the thin, perforated cribriform fascia, and which provides passage to the great saphenous vein to drain into the femoral vein in the femoral triangle, as well as the femoral branch of the genitofemoral nerve. When it comes to functions, the femoral canal allows the femoral vein to expand when venous return from the lower limb is increased, or when increased intra-abdominal pressure causes a temporary stasis or blockage in the vein. For example, this can occur during Valsalva maneuvers, which is when you ask the individual to exhale forcefully as if blowing up a balloon with a closed mouth and with the nose pinched shut. The canal also contains loose connective tissue, fat, a few lymphatic vessels, and sometimes a deep inguinal lymph node called the lacunar lymph node. Something else to know is that the proximal end of the femoral canal that opens up into the abdominal cavity is a femoral ring, about the size of the tip of the little finger. The femoral ring is bounded laterally by the vertical septum between the femoral canal and femoral vein, medially by the lacunar ligament, and posteriorly by the superior ramus of the pubis, which is covered by the pectineus muscle and its fascia, and anteriorly by the medial part of the inguinal ligament. Another important landmark is the adductor or subsartorial canal, which is an approximately 15 cm long intermuscular passageway deep to the sartorius in the middle third of the thigh. It extends from the tip of the femoral triangle to the adductor hiatus. The adductor canal is bounded anteriorly and laterally by the vastus medialis, posteriorly by the adductors longus and magnus, and medially by the sartorius, which overlies the groove between the aforementioned muscles, forming the roof of the canal. Purpose-wise, the adductor canal provides intermuscular passage for the femoral artery, vein, nerve to vastus medialis, and saphenous nerve, as well as delivering the femoral vessels to the popliteal fossa. Inferiorly, just proximal to the medial supracondylar ridge, the canal leads to a passageway called the adductor hiatus. This hiatus is an opening between the aponeurotic adductor and tendinous hamstring insertion of the adductor magnus. The adductor hiatus is a transition point for the femoral artery and vein to become the popliteal artery and vein during their course towards the popliteal fossa. Now, it's time we took a hiatus as well. Meanwhile, let's recall the boundaries and contents of the femoral triangle. Now that we know these particularities, we can talk about the structures within the femoral triangle. First up is the femoral nerve, which enters the thigh deep to an area near the midpoint of the inguinal ligament, which is midway between the anterior superior iliac spine and pubic tubercle, and enters the femoral triangle. Once in the thigh, it sends several branches to the anterior thigh muscles, articular branches to the hip and knee joints, and terminates as a saphenous nerve. The saphenous nerve then descends through the femoral triangle, accompanying the femoral artery and vein in the adductor canal, and goes superficial to the adductor hiatus and runs antero-inferiorly to supply skin and fascia on the anteromedial aspect of the knee, leg, and foot. Next, there's the femoral artery, which is the chief artery of the lower limb. The femoral artery is located in the anterior compartment and starts distal to the inguinal ligament as a continuation of the external iliac artery at the mid-inguinal point, which is halfway between the pubic symphysis and anterior superior iliac spine, and is different than the midpoint of the inguinal ligament. It moves on to enter and bisect the femoral triangle, passing deep to the midpoint of the inguinal ligament, where it is situated between the femoral nerve laterally and the femoral vein medially. The femoral artery continues its downward and medial trajectory from the femoral triangle through the adductor canal until it reaches the adductor hiatus. Here, the artery enters the popliteal fossa, where it continues as the popliteal artery. The femoral artery gives off plenty of branches along its trajectory. The largest branch is the profunda femoris artery, or deep artery of the thigh, which arises from the lateral or posterior side of the femoral artery and passes deep between the pectineus and adductor longus to become the main artery of the thigh. In the middle third of the thigh, where it is separated from the femoral artery and vein by the adductor longus, the profunda femoris gives 3 to 4 perforating arteries that wrap around the posterior aspect of the femur, supplying muscles in all 3 compartments of the thigh. The medial and lateral circumflex femoral arteries then encircle the uppermost proximal femur. These arise from the lateral side of the profunda femoris in the upper third of the thigh. The medial and lateral circumflex femoral arteries then encircle the uppermost shaft of the femur, almost like a warm, life-giving hug, and anastomose with each other and other arteries supplying the thigh muscles and superior end of the femur. The medial circumflex femoral artery supplies most of the blood to the head and neck of the femur via its branches, called the posterior retinacular arteries, while the lateral circumflex femoral artery mainly supplies muscles on the lateral side of the thigh. Also important to the blood supply of the thigh is the obturator artery, which branches from the internal iliac artery, although 20% of the time it's an accessory or replaced obturator artery from the inferior epigastric artery. The obturator artery passes through the obturator foramen to supply muscles of the medial compartment of the thigh, branching into an anterior and posterior division sandwiching the adductor brevis. Now, the femoral vein is a continuation of the popliteal vein proximal to the adductor hiatus. Okay, so from its origin at the adductor hiatus, the femoral vein ascends through the adductor canal, mostly posterior to the femoral artery. It then goes on and enters the femoral sheath lateral to the femoral canal and ends posterior to the inguinal ligament, where it becomes the external iliac vein. In the inferior part of the femoral triangle, the femoral vein receives the profunda femoris vein, the great saphenous vein, and other tributaries. The most important one is the profunda femoris vein, or deep vein of the thigh, which is formed by the union of 3 or 4 perforating veins. Okay, so now that we've reached the midpoint of the clip, just kidding, we're done. Now, before we recap, let's see if you remember the location of the main arteries and veins of the thigh. Alright, as a quick recap, the muscles of the anterior compartment of the thigh are innervated by the femoral nerve. First, the flexors of the hip include the pectineus, iliopsoas, which has a lateral part called the iliacus muscle and a medial part called the psoas major, and the sartorius. The second group, the extensors of the knee, is represented by the 4 components of the quadriceps femoris: vastus lateralis, vastus intermedius, vastus medialis, and the rectus femoris. Moving on, the muscles of the medial compartment of the thigh, mainly innervated by the obturator nerve, comprise the adductor group, which is made up of 5 muscles: adductor magnus, adductor brevis, adductor longus, gracilis, and obturator externus. Then, there's the femoral triangle, just distal to the inguinal ligament. It's bounded superiorly by the inguinal ligament, medially by the lateral border of the adductor longus, and laterally by the medial border of the sartorius. The muscular floor of the femoral triangle is formed by the iliopsoas laterally and the pectineus medially, while its roof is formed by the fascia lata and cribriform fascia, subcutaneous tissue, and skin. The structures inside the triangle can be recalled from lateral to medial using the naval mnemonic: the femoral nerve, femoral artery, femoral vein, the empty space where the femoral canal is, and the deep inguinal lymph nodes. The femoral sheath is a tube formed behind the inguinal ligament, and it terminates inferiorly by blending with the outer layer of the femoral vessels. The femoral canal starts at the inguinal ligament and extends distally to the proximal edge of the saphenous opening, and at its base is the oval femoral ring. Another landmark is the adductor canal, which extends from the apex of the femoral triangle to the adductor hiatus. The adductor canal provides a passage through which the neurovascular bundle of the thigh traverses the middle third of the thigh in their way towards the popliteal fossa. Inferiorly, the canal presents the adductor hiatus, an opening between the insertions of the adductor part and the hamstring part of the adductor magnus, which provides passage for the femoral artery and vein. The femoral nerve enters the femoral triangle deep to the inguinal ligament, sending several branches to anterior compartment muscles and terminating distally as a saphenous nerve. The femoral artery starts distal to the inguinal ligament as a continuation of the external iliac artery and travels through the adductor canal and reaches the adductor hiatus. Here, the artery enters the popliteal fossa, from where it continues as a popliteal artery. The femoral vein is a continuation of the popliteal vein, moving proximally from the adductor hiatus, from where it ascends through the adductor canal, enters the femoral sheath, and then it ends posterior to the inguinal ligament, where it becomes the external iliac vein. Both the femoral vein and artery give branches that supply different structures in the thigh. Finally, we have the obturator artery, which branches from the internal iliac artery and supplies the medial compartment.
Okay everyone, you are going to get a real kick out of this video because we're going to talk about the anatomy of the foot. The foot can be divided into two main parts: the sole or plantar region, which is the part of the foot contacting the ground, and the dorsum of the foot or the dorsal region, which is the part directed superiorly. Alternatively, it can be divided into three sections: the hindfoot, containing the talus and calcaneus, the midfoot, containing the navicular, cuboid, and cuneiforms, and the forefoot, which includes the metatarsals and phalanges. The foot also has two important landmarks: the heel, which is the sole of the foot underlying the calcaneus, and the ball of the foot, which is the sole underlying the heads of the medial two metatarsals. So let's talk a bit about the foot's components. The most superficial elements are skin and fascia, which vary in thickness and strength across the foot depending on if the area has roles in weight-bearing, ground contact, or compartmentalization. The skin on the dorsum of the foot is much thinner and less sensitive than the one on the sole. By contrast, the thick skin on the sole is ticklish, hairless, and has numerous sweat glands. The fascia of the foot can be divided into superficial and deep fascia. The superficial fascia, or the subcutaneous fat tissue, is loose and deep to the dorsal skin. It is much more fibrous in the sole and is thicker than in other areas of the foot, making the heel act as a shock-absorbing pad. The deep fascia of the dorsum of the foot is rather thin and continuous proximally with the inferior extensor retinaculum. It is also continuous with the plantar fascia, the deep fascia of the sole, over the lateral and posterior aspects of the foot. Speaking of which, the plantar fascia on the plantar aspect of the foot helps protect the sole from injury and supports the longitudinal arches of the foot. It consists of a thick central part called the plantar aponeurosis and weaker medial and lateral parts. The plantar aponeurosis is strong because it consists mostly of longitudinal bundles of dense, fibrous connective tissue that invests the central plantar muscles. These longitudinal fibers originate as a single entity on the medial process of the tuberosity of the calcaneus, and as they move towards the toes, they divide into 5 bands that become continuous with the fibrous digital sheaths that enclose the flexor tendons that pass to the toes. Each band splits opposite to the metatarsophalangeal joints into a superficial and a deep slip, blending with the skin and deeper ligaments of the distal foot and also embracing the flexor tendons to the toes. Now, in the midfoot and forefoot, the plantar aponeurosis has vertical intermuscular septa that extend superiorly from its margins toward the 1st and 5th metatarsals, forming the medial, central, and lateral compartments of the sole. The medial compartment is covered superficially by the thinner medial plantar fascia, and it contains muscles and neurovascular structures of the foot. The central compartment of the sole is covered by the dense plantar aponeurosis and contains muscles and tendons of the foot as well as neurovascular structures. There is also the lateral compartment of the sole, which is covered superficially by the thinner lateral plantar fascia. Additionally, there is an interosseous compartment of the foot containing the interosseous muscles and a few other structures, as well as the dorsal compartment of the foot, which has the extensor muscles of the foot passing through it. Now, the sole purpose of this section was to totally blow you away. And before we move on to the components of the foot, let's have a break and review its structure. So now let's look at the muscles of the foot. There are up to 20 individual muscles in the foot, and most of them are on the plantar surface. These plantar muscles are conveniently grouped into 4 different muscle layers. On an important side note, despite their compartmental and layered arrangement, the plantar muscles function primarily as a group during the support phase of the stance of walking, maintaining the arches of the foot. They essentially resist the forces that tend to reduce the longitudinal arch of the foot as weight is received at the heel, where the posterior end of the arch is, and then transferred to the ball of the foot and great toe, where the anterior end of the arch is. They also play a role in maintaining balance, and individually they help control the movement of the toes. Now, before we start, to help remember how many muscles are in each muscle layer, just think of 3-2-3-2. There are 3 muscles in the first layer, 2 groups of muscles in the second layer, 3 again in the third layer, and 2 in the fourth layer. To make that even easier to remember, think the odd layers, or the first and third, have 3 muscles, which is an odd number, and the even layers, 2 and 4, have an even 2 muscles each. So the 3 muscles in the first layer are the flexor digitorum brevis, abductor hallucis, and abductor digiti minimi. Flexor digitorum brevis lies immediately deep to the plantar aponeurosis. It originates on the medial tubercle of the calcaneal tuberosity and the plantar aponeurosis, then moves towards the toes and inserts on the middle phalanges of the 4 lateral toes. This muscle flexes the lateral 4 toes at the metatarsophalangeal and proximal interphalangeal joints. The abductor hallucis forms the medial margin of the foot, and it originates on the medial tubercle of the calcaneal tuberosity and plantar aponeurosis, from where it travels to and inserts on the medial side of the base of the proximal phalanx of the great toe. This muscle mostly abducts and flexes the great toe at the metatarsophalangeal joint. And finally, there is the abductor digiti minimi muscle, which is located on the lateral side of the foot. It originates on the lateral and medial tubercles of the calcaneal tuberosity and on the plantar aponeurosis. Then it inserts on the lateral side of the base of the proximal phalanx of the 5th digit, or pinky toe, which it flexes and abducts at the metatarsophalangeal joint. The second layer, composed of 2 muscles, is made up of the quadratus plantae muscle and the 4 lumbricals, which we will count as a group. The quadratus plantae is a square muscle located deep to the flexor digitorum brevis muscle. This muscle originates on the medial and lateral plantar surface of the calcaneus, and it inserts on the posterolateral margin of the tendon of flexor digitorum longus. By inserting on the flexor digitorum longus, it assists this muscle in flexing the lateral 4 digits. And then there are the four lumbricals, which counts as one for our 3-2-3-2 memory trick. They're located medial to and attached to their respective tendons of the flexor digitorum longus, like little satellites. This group of muscles causes flexion of the metatarsophalangeal joints and extension of both interphalangeal joints. The third layer has three muscles, the flexor hallucis brevis, flexor digiti minimi brevis, and adductor hallucis muscles. Flexor hallucis brevis is located on the medial side of the foot, and it originates from the plantar surfaces of the cuboid and lateral, or third cuneiform bone. It then splits into a medial and lateral head with its own tendon, with each tendon encompassing a sesamoid bone, and distally inserts to both sides of the base of the proximal phalanx of the great toe. This muscle flexes the proximal phalanx of the great toe at the metatarsophalangeal joint. Flexor digiti minimi brevis originates on the base of the fifth metatarsal. It travels to the tips of the toes and then attaches to the lateral side of the base of the pinky toe's proximal phalanx in order to flex the pinky at the metatarsophalangeal joint. And then there's the adductor hallucis muscle, which is located lateral to the flexor hallucis brevis. It consists of both an oblique and transverse head. The oblique head originates from the bases of the second, third, and fourth metatarsals. The transverse head originates from the plantar ligaments of the metatarsophalangeal joints. Both heads insert to the lateral base of the proximal phalanx of the great toe. Ultimately, this adductor, adducts the great toe and assists in maintaining the transverse arch of the foot. And the fourth and final layer is made up of two groups of muscles, the plantar interossei and dorsal interossei. Okay, so there are three plantar interossei that are located between the metatarsals. Each originates from the medial sides of the metatarsals of toes 3 to 5, and they insert on the medial sides of the proximal phalanges of digits 3 to 5. The plantar interossei adduct and flex toes 3 to 5 at the metatarsophalangeal joint. And finally, the four dorsal interossei are also located between the metatarsals, and each of them originates from the adjacent sides of the shafts of metatarsals 1 to 5. When it comes to insertions, the first dorsal interosseous muscle attaches to the medial side of the proximal phalanx of the second digit, whereas the second to fourth interossei attach to the lateral sides of the proximal phalanges of digits 2 to 4. The dorsal interossei abduct toes 2 to 4 and flex the metatarsophalangeal joints. A good way to remember the action of the three plantar interossei and four dorsal interossei is to remember the mnemonic 3 pad and 4 dab. This stands for the three plantar interossei adducting the toes and the four dorsal interossei abducting the toes. Now that we're done with the plantar muscles, let's also talk a bit about the dorsal ones. There are only two muscles located exclusively in the dorsal region of the foot, the extensor digitorum brevis and the extensor hallucis brevis. These muscles lie deep to the tendon of the extensor digitorum longus. They share a common muscle belly and originate from the calcaneus, and from this muscle belly 4 tendons arise and attach to the extensor expansion of digits 2 to 4. A portion of this muscle then goes on to attach to the base of the proximal phalanx of the great toe and is the extensor hallucis brevis muscle. These muscles extend digits 2 through 4 at the metatarsophalangeal and interphalangeal joints, and the great toe at the metatarsophalangeal joint. How about we take a break and review the muscles of the sole and dorsum? Let's move on to the nerves supplying the foot, starting with the 4 muscle layers of the foot, which are all innervated by either the medial or lateral plantar nerve, which are terminal branches of the tibial nerve. The medial plantar nerve is the larger and more anterior of the two terminal branches and arises deep to the flexor retinaculum. It enters the sole of the foot by passing deep to the abductor hallucis, then runs anteriorly between the abductor hallucis muscle and the flexor digitorum brevis in a neurovascular plane between the first and second muscular layer, supplying both the abductor hallucis and flexor digitorum brevis motor branches. The medial plantar nerve then provides motor branches to the flexor hallucis brevis and first lumbrical muscle, and a sensory branch that goes on to innervate the skin on the medial side of the sole. Finally, the medial plantar nerve terminates near the bases of the metatarsals by dividing into three sensory branches called the common plantar digital nerves. These branches supply sensory information for the skin of the medial 3.5 digits, including the dorsal skin and nail beds of their distal phalanges and the skin of the sole proximal to them. So, in total, the medial plantar nerve innervates two muscles in the first layer, then one muscle in the second layer, and one muscle in the third layer, along with its cutaneous innervation. Next, the lateral plantar nerve, which is the smaller and more posterior of the two terminal branches, also courses deep to the abductor hallucis but runs anterolaterally between the first and second layers of plantar muscles. The lateral plantar nerve terminates as it reaches the lateral compartment, dividing into superficial and deep branches, where the deep branch courses in a neurovascular plane between the third and fourth muscle layers. The lateral plantar nerve, along with its superficial and deep branches, innervate the rest of the muscles on the plantar surface of the foot not innervated by the medial plantar nerve. This means the lateral plantar nerve provides motor innervation to the abductor digiti minimi in the first layer and the quadratus plantae in the second layer. Meanwhile, its deep branch gives motor innervation to the lateral three lumbricals. Then in the third layer, it innervates the adductor hallucis, while the superficial branch provides motor innervation to flexor digiti minimi brevis. Finally, in the fourth layer, the deep branch innervates all of the plantar and dorsal interossei. In regards to cutaneous sensory innervation, the superficial branch divides and goes on to supply the skin of the plantar aspects of the lateral 1.5 digits, the dorsal skin and nail beds of their distal phalanges, and the skin of the sole proximal to them. The rest of the cutaneous innervation of the foot is supplied medially by the saphenous nerve, laterally by the sural nerve, on the dorsum of the foot by the superficial and deep fibular nerves, inferiorly on the sole of the foot by the medial and lateral plantar nerves, as we said before, and posteriorly at the heel by the medial and lateral calcaneal branches of the tibial and sural nerves, respectively. First, the saphenous nerve is the longest and most widely distributed cutaneous branch of the femoral nerve and passes anterior to the medial malleolus to the dorsum of the foot, where it supplies skin along the medial side of the foot as far anteriorly as the head of the first metatarsal. Second, the sural nerve is formed by branches of the tibial and common fibular nerve, and it usually passes inferior to the lateral malleolus, where it accompanies the small saphenous vein and supply the ankle joint and skin along the lateral margin of the hind and midfoot. Next, we have the superficial and deep fibular nerves, both branches of the common fibular nerve. When it comes to the superficial fibular nerve, it supplies sensory information to the skin on the anterolateral aspect of the leg, and its branches continue across the ankle to supply most of the skin on the dorsum of the foot. Its terminal branches supply the skin of the dorsal aspect of the medial half of the great toe and that of the lateral 3.5 digits. And second, the deep fibular nerve supplies motor innervation to the intrinsic muscles on the dorsum of the foot, the extensor digitorum brevis and the extensor hallucis brevis, and emerges as a cutaneous nerve to supply sensory innervation to only a small area of skin that remains available for innervation, the web of skin between and contiguous sides of the first and second toes. Okay, so it's time to put an end to this nerve-ending story. Before we switch to blood vessels, let's see if you can remember what each nerve of the foot innervates. Moving on to blood vessels, the main arteries of the foot are the plantar arteries and the dorsalis pedis artery. Dorsalis pedis is the terminal branch of the anterior tibial artery. The plantar arteries are the terminal branches of the posterior tibial artery and make up the prolific blood supply of the sole of the foot. There are two main plantar arteries, namely the medial and lateral plantar arteries, which typically follow their similarly named medial and lateral plantar nerve. The medial plantar artery is the smaller terminal branch of the posterior tibial artery. It arises beneath the flexor retinaculum and appears in the sole deep to abductor hallucis, usually accompanied by the medial plantar nerve on its lateral side. It terminates on the medial side of the big toe by dividing into two branches. The smaller one is called the deep branch, and it mainly supplies the muscles of the great toe. The larger one is called the superficial branch, and it supplies the skin on the medial side of the sole and has digital branches that accompany the digital branches of the medial plantar nerve, the more lateral of which anastomose with medial plantar metatarsal arteries. Occasionally, a superficial plantar arch is formed when the superficial branch anastomoses with the lateral plantar artery or the deep plantar arch. Second, the lateral plantar artery arises with and accompanies the lateral plantar nerve. From its origin, the artery runs laterally and anteriorly, at first deep to the abductor hallucis, and then between the flexor digitorum brevis and quadratus plantae. Ultimately, the lateral plantar artery arches medially across the foot with the deep branch of the lateral plantar nerve to form the deep plantar arch, which is completed by the union with the deep plantar artery, a branch of the dorsalis pedis artery. As it crosses the foot, the deep plantar arch gives rise to four plantar metatarsal arteries. The plantar metatarsal arteries divide near the base of the proximal phalanges to form the plantar digital arteries, supplying adjacent toes. The plantar digital arteries typically provide most of the blood reaching the distal toes, including the nail bed, via perforating and dorsal branches. Now let's switch gears and look at the dorsalis pedis artery, which directly continues the anterior tibial artery. It begins midway between the malleoli and runs anteromedially on the lateral side of the extensor hallucis longus and the extensor digitorum longus tendons on the dorsum of the foot. This is the artery that we palpate when we locate the pulse on the foot, and it can be easily found by lifting up the big toe and going lateral to the tendon of the extensor hallucis longus. The dorsalis pedis artery then passes to the first interosseous space, where it divides into the first dorsal metatarsal artery and a deep plantar artery. The deep plantar artery passes deep between the heads of the first dorsal interosseous muscle to enter the sole of the foot, where it joins the lateral plantar artery to form the deep plantar arch. Now, the dorsalis pedis also gives off plenty of branches, such as the lateral tarsal artery, which runs laterally in an arched course beneath the extensor digitorum brevis to supply this muscle and the underlying tarsals and joints. Then there's the arcuate artery, which runs laterally across the bases of the lateral four metatarsals, deep to the extensor tendons to reach the lateral aspect of the forefoot, where it may or may not anastomose with the lateral tarsal artery to form an arterial loop. Additionally, the arcuate artery gives rise to the second, third, and fourth dorsal metatarsal arteries. These vessels run distally to the toes and are connected to the plantar arch and the plantar metatarsal arteries by perforating branches. Distally, each dorsal metatarsal artery divides into two dorsal digital arteries for the dorsal aspect of the sides of adjoining toes. Venous drainage of the foot is ensured by both superficial and deep veins within the foot. Most of the blood of the foot is drained by the superficial venous drainage, which is located in the subcutaneous tissue and unaccompanied by arteries. Superficial veins are mostly a series of small veins like the dorsal digital veins, of which there are 2 on each toe. Each joins the corresponding vein of the adjacent toe, along with plantar digital veins, to form the dorsal metatarsal veins, which terminates in the dorsal venous arch of the foot, proximal to which a dorsal venous network covers the remainder of the dorsum of the foot. On the plantar surface of the foot, superficial veins form a plantar venous network which can drain around the medial border of the foot and converge with the medial part of the dorsal venous arch to form a medial marginal vein, eventually becoming the great saphenous vein. Or the plantar venous network drains in the lateral margin and converges with the lateral part of the dorsal venous arch to form the lateral marginal vein, which becomes the small saphenous vein. The deep veins are an anastomosing network of paired veins that accompany all arteries internal to the deep fascia. Finally, just a few words on the lymphatics of the foot. There are both superficial and deep lymphatic vessels that follow the superficial veins and major vascular bundles. The medial superficial lymphatic vessels are the largest and drain the medial side of the dorsum and sole of the foot. These vessels converge on the great saphenous vein and accompany it to the vertical group of superficial inguinal lymph nodes and then to the deep inguinal lymph nodes along the proximal femoral vein. On the other hand, the lateral superficial lymphatic vessels drain the lateral side of the dorsum and sole of the foot, and most of these vessels accompany the small saphenous vein to the popliteal fossa, where they enter the popliteal lymph nodes. The deep lymphatic vessels follow the main blood vessels: fibular, anterior and posterior, tibial, popliteal, and femoral veins. These lymphatic vessels also drain into the popliteal lymph nodes, and from them follow the femoral vessels, carrying lymph to the deep inguinal lymph nodes and eventually to the iliac lymph nodes. Terrific! We've reached the end. Before recap, let's take a break and see if you can remember the main vessels of the foot. Alright, as a quick recap, the most superficial elements of the foot are skin and fascia. The deep plantar fascia has a central part called the plantar aponeurosis that gives off vertical intermuscular septa. The septa form the 3 compartments of the sole: medial, central, and lateral, each containing many plantar structures of the foot. The muscles of the sole can be divided in 4 layers. The first layer consists of 3 muscles: flexor digitorum brevis, abductor hallucis, and abductor digiti minimi. The second layer contains the quadratus plantae muscle and the group of 4 lumbricals. The third layer includes another 3 muscles, the flexor hallucis brevis, flexor digiti minimi brevis, and adductor hallucis muscles. And the fourth layer is made up of the plantar and dorsal interossei. The dorsal region only has 2 muscles, the extensor digitorum brevis and the extensor hallucis brevis. The innervation to the 4 muscle layers is provided by one of the terminal branches of the tibial nerve, either the medial or the lateral plantar nerve. The cutaneous innervation of the foot is handled by several nerves, including the saphenous nerve, the sural nerve, the superficial and deep fibular nerve, as well as the medial and lateral plantar nerves. Next, arteries. The medial and lateral plantar arteries course with their respective nerves. The lateral plantar artery forms the deep plantar arch alongside the deep plantar artery, a branch of the dorsalis pedis artery. The dorsalis pedis artery is a direct continuation of the anterior tibial artery. The deep veins of the foot course with their respective arteries, while superficial venous drainage is ensured by a dorsal and plantar venous network, which receives a series of smaller veins distally. Finally, the medial superficial lymphatic vessels accompany the great saphenous vein to the superficial and deep inguinal lymph nodes. The lateral superficial lymphatic vessels accompany the small saphenous vein to the popliteal fossa, where they enter the popliteal lymph nodes. The deep lymphatic vessels of the foot follow the main blood vessels and also drain into the popliteal lymph nodes and eventually travel to the deep inguinal and subsequent iliac lymph nodes.
If you have ever wanted to know about the new hip joint in town, look no further than the hip joint. The hip joint is a large, strong joint connecting the pelvis to the lower limb. Let's take a closer look. The hip joint is a synovial ball and socket joint where the head of the femur forms approximately 2/3 of a sphere, and it articulates with the cup-like acetabulum of the hip bone. The femoral head is not entirely round, as it has a depression on the top of it, which is called the fovea, for the ligament of the head of the femur. Except for the fovea, the femoral head is also covered entirely in articular cartilage, which facilitates smooth movement and prevents bone erosion as it slides within the acetabulum. The acetabulum, on the other hand, is a bowl-like structure on the lateral aspect of the hip bone, and you might remember it's formed by the fusion of the ilium, ischium, and pubis. The acetabulum is surrounded on the outside by a margin that's incomplete inferiorly where the acetabular notch is situated. This makes it look like a bowl with a broken rim. On the outside of the acetabular margin, there's the acetabular labrum, where labrum is a fancy word for lip, which continues over the acetabular notch with the transverse acetabular ligament. The labrum increases the surface area of the acetabulum to allow for more than half of the femoral head to fit within the acetabulum for stability. There's also a rough depression in the floor of the acetabulum, the acetabular fossa, right above the notch. These two structures, the acetabular notch and fossa, are surrounded by the thick and smooth lunate surface, the articular surface on which the head of the femur slides. Just like most joints, the hip joint is enclosed within a strong joint capsule formed by an external fibrous layer, called the fibrous capsule, and an internal layer called the synovial membrane. The fibrous layer attaches proximally to the acetabulum peripheral to the acetabular margin, as well as to the transverse acetabular ligament. Distally, it attaches to the femoral neck. Anteriorly, at the intertrochanteric line and root of the greater trochanter, and posteriorly, the fibrous layer heads towards, but doesn't attach to, the intertrochanteric crest. Instead, most of its fibers take a spiral course and attach to the intertrochanteric line of the femur, whereas some deep fibers pass circularly around the neck, forming the orbicular zone, which may play a role in stability. The fibrous layer is actually thicker in some places, where it forms the 3 intrinsic ligaments of the hip joint, which pass in a spiral from the pelvis to the femur, a bit like curled pasta made of fibrous tissue. Anteriorly and superiorly is the strong, Y-shaped iliofemoral ligament, which attaches to the anterior inferior iliac spine and the acetabular rim proximally, and the intertrochanteric line distally. Considered the body's strongest ligament, the iliofemoral ligament tightens and brings the femoral head tightly into the acetabulum when standing upright. This prevents the hyperextension of the hip joint. Anteriorly and inferiorly, there's the pubofemoral ligament, which arises from the obturator crest of the pubic bone and passes laterally and inferiorly to merge with the fibrous layer of the joint capsule and blends with the medial part of the iliofemoral ligament. The pubofemoral ligament tightens during extension and abduction of the hip joint, preventing overabduction. And finally, posteriorly, there's the ischiofemoral ligament, which goes from the acetabular margin to the neck of the femur. This ligament spirals superlaterally to the femoral neck, medial to the base of the greater trochanter, and it limits internal rotation of the hip. The synovial layer, the other component of the joint capsule, lines the internal surfaces of the fibrous layer, as well as any intracapsular bony surface not lined with articular cartilage. More specifically, it covers the neck of the femur between the attachment of the fibrous capsule and the edge of the articular cartilage of the head, as well as the non-articular area of the acetabulum. Speaking of which, the synovial membrane covering the femoral neck presents longitudinal synovial folds through which course the subsynovial retinacular arteries, which branch from the medial and lateral circumflex femoral arteries that supply the femoral head and neck. The synovial layer also gives off the ligament of the head of the femur, also called the ligamentum teres, which houses the artery to the head of the femur, a branch of the obturator artery. The ligament of the head of the femur attaches to the margins of the acetabular notch, along with the transverse acetabular ligament, and to the fovea on the femoral head. The ligament lays within the acetabular fossa, cushioned by a fat pad that fills the part of the fossa not occupied by the ligament of the head of the femur. Quite cozy. Okay, now that we know our hip joint players, let's look at the hip joint movements and identify the main muscles that produce them. For example, flexion is produced by the iliopsoas, sartorius, rectus femoris, and pectineus. Extension is produced by gluteus maximus and the hamstrings, and it's limited by the tightening of the iliofemoral ligament. Abduction is carried out by the gluteus minimus and medius, tensor fascia lata, and sartorius. Adduction is a job for the adductor longus, brevis, and magnus, and for the pectineus and gracilis muscles. Medial rotation is achieved with a little help from the gluteus minimus and medius, and from the tensor fascia lata. And finally, lateral rotation is partly produced by the short lateral rotator group, piriformis, obturator externus, obturator internus, and associated gemelli, and quadratus femoris, but primarily by the gluteus maximus. The hip joint is also capable of circumduction, which is a combination of all of the movements mentioned earlier. Now, all these movements wouldn't be possible without arteries nourishing the hip joint, of course. The large arteries in this area are the medial and lateral circumflex femoral arteries. The medial circumflex femoral artery is a branch of the profunda femoris artery. It passes posteriorly and gives off the transverse and descending branches. The transverse branch takes part in the formation of cruciate anastomosis, which is situated at the upper part of the back of the femur at the level of the lesser trochanter, whereas the ascending branch passes to the trochanteric fossa, where it takes part in the formation of the trochanteric anastomosis. It also gives off posterior retinacular branches, which supply the head and neck of the femur. The lateral circumflex femoral artery is the largest branch of the profunda femoris artery. It runs laterally and divides into ascending, transverse, and descending branches. The ascending branch contributes to the trochanteric anastomosis, and the transverse branch wraps around the femur posteriorly to take part in the cruciate anastomosis. The descending branch runs down along the anterior border of the vastus lateralis, which it supplies, and perforates to anastomose with a branch of the popliteal artery. The trochanteric anastomosis is also joined by the branches from the inferior gluteal artery and superior gluteal artery, while the cruciate anastomosis is also joined by a branch from the first perforating artery and by a branch of the inferior gluteal artery. Now let's look at the retinacular arteries in more detail. Generally speaking, these arteries run along the neck of the femur and through the retinaculum of the capsule, hence their name. Retinacular arteries arising from the medial circumflex femoral artery are more numerous and supply most of the head and neck of the femur because they are able to pass beneath the unattached posterior border of the joint capsule. Retinacular arteries arising from the lateral circumflex femoral penetrate the thick iliofemoral ligament. There's fewer of them, and they are smaller. And one last important blood supply is the artery to the head of the femur, which is a branch of the obturator artery. It varies in size, and it traverses the ligament of the head of the femur. When it comes to nerve supply, the hip abides by the Hilton's law, which states that the nerves supplying the muscles crossing a joint also innervate that said joint, usually through direct articular branches. So if you know the muscles that cross a specific joint and the nerves that supply those muscles, you can deduce the nerve supply of the joint. For example, the hip joint is crossed anteriorly by the flexors of the hip, which are innervated by the femoral nerve. So the anterior aspect of the hip joint is innervated by the femoral nerve. The rest of the hip joint is innervated by the sciatic, obturator, and superior gluteal nerve. That is what we call information overload. Because we don't want you to strain your brain muscle, let's take a break and see if you can identify some of the most important elements of the hip joint. All right, as a quick recap, the hip joint is a ball and socket type of synovial joint that is enclosed within a joint capsule formed by a fibrous and a synovial layer. The fibrous layer of the joint capsule gives off three intrinsic ligaments of the hip joint: the iliofemoral ligament, the pubofemoral ligament, and the ischiofemoral ligament. The synovial layer gives off the ligament of the head of the femur, which conducts the artery to the head of the femur. Hip joint movements include flexion, extension, adduction, abduction, internal and external rotation.
The knee joint is a large hinge type of synovial joint, allowing flexion and extension of the lower limb. The knee joint has three main articular areas: the lateral and medial femorotibial articulations between the lateral and the medial condyles of the femur and tibia, as well as the intermediate femoropatellar articulation between the patella and the femur. Notice that the fibula does not participate in the knee joint. Okay, now the articular surfaces of the knee joint are the medial and lateral femoral condyles, the patellar surface of the femur between these two condyles, the articular surface of the patella, which is a plateau with an antero-posterior ridge that fits into the patellar surface known as the trochlear groove, and the articular surfaces of medial and lateral condyles of the tibia, on which the condyles of the femur roll. Because the knee joint articular surfaces are irregularly shaped and incongruent, knee joint stability heavily relies on tibiofemoral ligaments and the strength of the surrounding muscles such as the quadriceps. Now, the knee joint is surrounded by a joint capsule, which has an external fibrous capsule and an internal synovial membrane. Superiorly, the fibrous capsule attaches to the femur, just proximal to the articular margins of the condyles. Posteriorly, the fibrous layer encloses the condyles and the intercondylar fossa, and has an opening for the tendon of the popliteus. Inferiorly, the fibrous layer attaches to the margin of the tibial plateau, except where the tendon of the popliteus crosses the bone. The quadriceps tendon, patella, and patellar ligament replace the fibrous layer anteriorly, and the fibrous capsule is continuous with the medial and lateral margins of these anterior structures. Then, the extensive synovial membrane lines all surfaces bounding the articular cavity not covered by articular cartilage, so it can be found attaching to the periphery of the articular cartilage covering both the femoral and tibial condyles, the posterior surface of the patella, and edges of the menisci. Now, the synovial membrane lines the internal surface of the fibrous joint capsule of the knee, both medially and laterally. However, it does not line the fibrous joint capsule centrally in the posterior knee. From this view, we can see the famous anterior and posterior cruciate ligament, And as you can see, the synovial membrane actually reflects anteriorly over these anterior surfaces of the cruciate ligaments into the intercondylar region instead of going behind them. Meaning the cruciate ligaments actually lie posterior and outside of the synovial-lined articular cavity, so they're considered extra-articular, in addition to lining the posterior surface of the infrapatellar fat pad, making this extra-articular as well. The anterior synovial reflection creates a median infrapatellar synovial fold. Above the patella, the synovial membrane of the joint capsule extends underneath the central part of the quadriceps to continue with the synovial lining of the suprapatellar bursa. Now, the joint capsule is strengthened by 6 extracapsular, external, or intrinsic ligaments. These include the fibular or lateral collateral ligament, tibial or medial collateral ligament, anterolateral ligament, patellar ligament, oblique popliteal ligament, and arcuate popliteal ligament. The patellar ligament, the distal part of the quadriceps femoris tendon, is a thick fibrous band passing from the apex and adjoining margins of the patella to the tibial tuberosity. On its lateral sides, it is joined by the medial and lateral patellar retinacula, which are expansions of the vastus medialis and vastus lateralis respectively, which form the joint capsule in their respective areas and help maintain alignment of the patella throughout its movement during knee flexion and extension. The collateral ligaments are 2 strap-like ligaments on the medial and lateral surface of the knee, and they contribute to knee stability by limiting varus and valgus movements of the knee, while also contributing to rotational stability. The tibial collateral ligament is a flat band that extends from the medial epicondyle of the femur to the medial condyle of the tibia, with its deep fibers firmly attached to the medial meniscus at its midpoint. The tibial collateral ligament is a thickened portion of the medial joint capsule and is mirrored by a lateral joint capsule thickening which has garnered recent anatomical interest called the anterolateral ligament. The anterolateral ligament of the knee generally inserts on the lateral epicondyle of the femur to the lateral surface of the tibia, and also has a midpoint attachment to the lateral meniscus. Then there's the lateral or fibular collateral ligament, which is a cord-like extracapsular ligament that extends inferiorly from the lateral epicondyle of the femur to the lateral surface of the fibular head. Then there's the oblique popliteal ligament, which is an expansion of the tendon of the semimembranosus that reinforces the joint capsule posteriorly. The ligament arises posterior to the medial tibial condyle and passes superolaterally toward the lateral femoral condyle, blending with the central part of the posterior aspect of the joint capsule. And finally, the arcuate popliteal ligament strengthens the joint capsule posterolaterally. It arises from the posterior aspect of the fibular head and spreads over the posterior surface of the knee joint. Both the oblique and the arcuate popliteal ligament are thought to contribute to posterolateral stability of the knee. The knee joint is also strengthened by the intracapsular structures, which include the cruciate ligaments and menisci. The 2 cruciate ligaments are located within the fibrous joint capsule, so they are intracapsular, but lie outside of the synovial-lined articular cavity, as we said before, so are considered extra-articular. The anterior cruciate ligament, or ACL, arises from the anterior intercondylar area of the tibia, posterior to the attachment of the medial meniscus. It extends superiorly, posteriorly, and laterally to attach to the posterior part of the medial side of the lateral condyle of the femur. The ACL serves to prevent anterior translation of the tibia in relation to the femur, and it also helps prevent hyperextension and excessive internal rotation of the knee. The posterior cruciate ligament, or PCL, is stronger than its brother, the ACL, and it arises from the posterior intercondylar area of the tibia. It then passes superiorly and anteriorly on the medial side of the ACL to attach to the anterior part of the lateral surface of the medial condyle of the femur. The PCL prevents posterior translation of the tibia in relation to the femur and helps to prevent hyperflexion of the knee. And now for the two menisci of the knee joint, which are small, C-shaped discs found within the synovial cavity that are considered intra-articular. The menisci have thick external margins which become thinner as you move medially, and unattached edges in the interior of the joint. The menisci are made of fibrocartilage and are placed on the articular surface of the tibia and function to allow for joint congruency, load distribution, and joint stability of the knee. First, the medial meniscus is C-shaped and broader posteriorly than anteriorly. Its anterior end is attached to the anterior intercondylar area of the tibia, and its posterior end is attached to the posterior intercondylar area. The medial meniscus also firmly adheres to the deep surface of the tibial collateral ligament. Speaking of which, the lateral meniscus is nearly circular, smaller, and more freely movable than the medial meniscus. The lateral meniscus also has an intimate relationship with the tendon of the popliteus, whose medial part of the tendon attaches to the posterior horn of the lateral meniscus. Its anterior end is attached to the anterior intercondylar area of the tibia, and its posterior end is attached to the posterior intercondylar area. Finally, the anterior edges of the menisci are joined by the transverse ligament of the knee. Now, although we'd love to spare you the details, there are also about 12 bursae around the knee, which are fluid-filled structures that help reduce friction between muscles, tendons, and skin during movement. The most important ones are the subcutaneous prepatellar bursa and infrapatellar bursa, which are located between the anterior patella and the skin and tibial tuberosity respectively, and the deep infrapatellar bursa, which is located between the anterior surface of the tibia and the patellar ligament. Next are the four bursae that communicate with the synovial cavity of the knee joint. These are the suprapatellar bursa, located between the anterior surface of the lower part of the femur and deep surface of the quadriceps femoris, the popliteus bursa between the tendon of popliteus and the lateral condyle of the tibia, the anserin bursa, which is deep to the tendinous distal attachments of the sartorius, gracilis, and semitendinosus, and finally, the gastrocnemius bursae, which are deep to the proximal attachments of the medial and lateral gastrocnemius head tendons. The two main movements of the knee joint are flexion, primarily produced by the hamstrings, and extension, which is primarily produced by the quadriceps femoris. When standing with feet fixed on the ground, the knee passively locks due to medial rotation of the femoral condyles as they rest on the tibial plateau, allowing us to stand for long periods without fatiguing our quadriceps. When the popliteus muscle contracts, it laterally rotates the femur, helping us unlock our knee so flexion can occur, which is also crucial for initiating our gait. More minor movements of the knee are medial rotation, primarily done by the semitendinosus and semimembranosus, as well as lateral rotation, primarily done by the biceps femoris. When it comes to muscles that contribute to the stability of the knee, these include the quadriceps femoris, sartorius, popliteus, gracilis, biceps femoris, semitendinosus, and semimembranosus. Switching now to neurovascular supply. The arteries supplying the knee joint are the vessels that form the periarticular genicular anastomosis around the knee. The 5 genicular branches of the popliteal artery include the superior lateral, superior medial, inferior lateral, inferior medial, and middle genicular arteries, the descending genicular branch of the femoral artery, the descending branch of the lateral circumflex femoral artery, 2 recurrent branches of the anterior tibial artery, and the circumflex fibular branch of the posterior tibial artery. And going back to Hilton's law, the nerves supplying the muscles crossing the knee joint also supply the joint. These include the articular branches from the femoral, tibial, and common fibular nerves, as well as the saphenous nerve. Although we really are knee-deep in this fascinating topic, perhaps it's time to have a small break and try to recognize some of the structures of the knee joint. All right, as a quick kneecap, Sorry, quick recap. The knee joint is a hinge type of synovial joint between the femur, tibia, and patella, and a joint capsule also formed by a fibrous and synovial layer. The joint has 6 extracapsular ligaments: the patellar ligament, the tibial and fibular collateral ligament, the anterolateral ligament, the oblique popliteal ligament, and the arcuate popliteal ligament. It also has intra-articular structures, including the anterior cruciate ligament, posterior cruciate ligament, and the medial and lateral menisci. The important bursae around the knee are the subcutaneous prepatellar and infrapatellar bursae, and the 4 bursae that communicate with the synovial cavity of the knee joint: the suprapatellar bursa, the popliteus bursa, the anserine bursa, and finally, the gastrocnemius bursa. Knee joint movements include flexion, extension, medial rotation, and lateral rotation.
The leg is the region of the lower limb between the knee and the ankle. It's a tightly packed region consisting of muscles and neurovascular structures. The leg is organized into 3 fascial compartments: anterior, lateral, and posterior, which are formed by the interosseous membrane, the anterior intramuscular septum, and the posterior intramuscular septum. The anterior compartment of the leg is also known as the extensor or dorsiflexor compartment, and it's the area of the body you use to locate furniture after you turn off the lights. Ouch! It's bound anteriorly by the deep fascia of the leg and skin, posteriorly by the interosseous membrane, medially by the lateral surface of the tibia, and laterally by the anterior intramuscular septum and the medial surface of the fibula. Now, proximally, the deep fascia overlying the anterior compartment is dense, providing part of the proximal attachment of the muscle immediately deep to it, the tibialis anterior. Distally, the deep fascia presents 2 band-like thickenings organized as 2 retinocula. Retinocula help secure and provide leverage for the tendons of the anterior compartment muscles before and after they cross the ankle joint. Specifically, the retinocula prevent these tendons from bowstringing anteriorly during movement of the joint. First, there's the superior extensor retinoculum, which is a strong, broad band of deep fascia passing from the fibula to the tibia proximal to the malleoli. Second, there's the inferior extensor retinoculum, a Y-shaped band of deep fascia that attaches laterally to the anterosuperior surface of the calcaneus and medially to the medial malleolus and medial cuneiform. It forms a strong loop around the tendons of the fibularis tertius and the extensor digitorum longus muscles. The anterior compartment contains 4 muscles: the tibialis anterior, extensor digitorum longus, extensor hallucis longus, and fibularis tertius, which are all dorsiflexors of the ankle, raising the toes and depressing the heel. To remember dorsiflexion, think of the phrase fins to shins, with your toes being the fins you use to swim and you're bringing them up to your shins. The muscles in the anterior compartment are innervated by the deep fibular nerve, and blood is supplied via the anterior tibial artery. The tibialis anterior is the most medial and superficial dorsiflexor, and it lies against the lateral surface of the tibia. It originates on the lateral condyle in the superior half of the lateral surface of the tibia and the interosseous membrane. About halfway down the leg, its muscular fibers are replaced by the muscle's tendon, which continues its descent along the anterior surface of the tibia. It passes deep to the superior and inferior extensor retinocula and inserts to the medial and inferior surfaces of the medial cuneiform and the base of the first metatarsal. The tibialis anterior is the strongest dorsiflexor of the ankle, and it also helps produce inversion, or turning of the sole of the foot inwards. Second, the extensor digitorum longus is the most lateral of the anterior leg muscles. Its origin is at the lateral condyle of the tibia and the superior 3/4 of the medial surface of the fibula and interosseous membrane. The extensor digitorum longus forms 4 tendons superior to the ankle, which enter the dorsum of the foot along with the tendon of the closely associated fibularis tertius muscle. Once the tendons reach the phalanges, they divide into 2 lateral bands and 1 central band. The central band inserts into the base of the middle phalanx, and the lateral bands converge to insert into the base of the distal phalanx. The extensor digitorum longus extends the lateral 4 digits and dorsiflexes the ankle. Third, the extensor hallucis longus is a thin muscle that lies deeply between the tibialis anterior and extensor digitorum longus. Its origin is the middle part of the anterior surface of the fibula and interosseous membrane. The muscle courses distally along the crest of the dorsum of the foot to the great toe, and it inserts on the dorsal aspect of the base of the distal phalanx of the great toe. The muscle extends to the great toe and, unsurprisingly, also dorsiflexes the ankle. And finally, the fibularis tertius, which proximally originates on the inferior third of the anterior surface of the fibula and interosseous membrane and inserts on the dorsum of the 5th metatarsal. The fibularis tertius dorsiflexes the ankle, and it also participates in eversion of the ankle, or turning the sole of the foot outwards. Now, let's talk about the neurovascular structures in the anterior compartment of the leg. The main nerve of the anterior compartment is the deep fibular nerve. It's one of the 2 terminal branches of the common fibular nerve, arising between the fibularis longus muscle and the neck of the fibula. After its entry into the anterior compartment, the deep fibular nerve accompanies the anterior tibial artery, first between the tibialis anterior and extensor digitorum longus, and then between the tibialis anterior and extensor hallucis longus. It then exits the compartment at the distal end of the tibia and enters the dorsum of the foot. Now, along its way, it sends motor branches to the anterior muscles of the leg and dorsum of the foot. Finally, it provides sensory innervation to the skin of the first interdigital cleft, which is the skin between the first and the second toe, as well as to the joints it crosses via articular branches. Finally, the anterior compartment is mainly supplied by the anterior tibial artery, which is the smaller terminal branch of the popliteal artery. The anterior tibial artery begins at the inferior border of the popliteus muscle and immediately passes anteriorly through a gap in the superior part of the interosseous membrane, which it descends on its anterior surface between the tibialis anterior and extensor digitorum muscles. At the ankle joint, midway between the malleoli, the anterior tibial artery changes names, becoming the dorsalis pedis artery. Well, that was, shall I say, legendary? How about a quick break to see if you can recognize the main structures of the anterior compartment of the leg? Moving on to the lateral compartment of the leg, or the everter compartment, this space is bound medially by the lateral surface of the fibula, laterally by deep fascia of the leg, anteriorly by the anterior intermuscular septum, and posteriorly by the posterior intermuscular septum. From its superior limit at the level of the popliteal fossa, the lateral compartment ends inferiorly at the superior fibular retinaculum. The lateral compartment contains 2 fibularis muscles, longus and brevis. The fibularis longus, as its name suggests, is the longer and more superficial of the 2 fibularis muscles. It originates on the head and superior 2/3 of the lateral surface of the fibula. From this point, it travels distally behind the lateral malleolus and deep to the inferior fibular retinaculum. It eventually enters a groove on the antero-inferior aspect of the cuboid as it crosses the sole of the foot, running obliquely and distally to reach its insertion on the base of the first metatarsal and medial cuneiform bones. The fibularis brevis lies deep to the fibularis longus, and it's the shorter of the 2. It originates on the inferior 2/3 of the lateral surface of the fibula, and its fibers converge to form a tendon which passes posterior to the lateral malleolus. It passes anteriorly and laterally to insert on the dorsal surface of the tuberosity of the fifth metatarsal. The fibularis brevis helps maintain the lateral longitudinal arch of the foot. Both fibularis muscles help with eversion and contribute to weak plantar flexion at the ankle. The superficial fibular nerve, which is the other terminal branch of the common fibular nerve, innervates the lateral compartment. It arises between the most proximal attachment of the fibularis longus and the neck of the fibula, from where it descends down the leg until it pierces the deep fascia at the distal third of the leg to become subcutaneous. Now, the superficial fibular nerve supplies motor innervation to the fibularis muscles and sensory innervation to the skin on the distal part of the anterior surface of the leg and nearly all of the dorsum of the foot. When it comes to arteries and veins, the lateral compartment does not have a major blood vessel coursing through it. Instead, perforating branches and accompanying veins supply blood to and drain blood from the lateral compartment. Proximally, perforating branches of the anterior tibial artery and their accompanying veins penetrate the anterior intermuscular septum. Distally, perforating branches of the fibular artery and accompanying veins penetrate the posterior intermuscular septum. Now that was a lot of info. Let's take a break now and try to recognize the components of the lateral compartment of the leg. And finally, we've reached the posterior compartment of the leg, or the plantar flexor compartment, which is the largest of the three. Now, the posterior compartment is divided into a superficial and a deep subcompartment by the transverse intermuscular septum. The superficial subcompartment is larger, and its borders are the transverse intermuscular septum anteriorly and the skin posteriorly, while the deep subcompartment is smaller and sits posterior to the tibia, fibula, and the interosseous membrane. Inferiorly, the deep subcompartment tapers and becomes smaller distally, and the distal transverse intermuscular septum fibers extend between the tip of the medial malleolus and the calcaneus as the flexor retinaculum. This retinaculum creates a compartment for the tendons and neurovascular structures of the posterior compartment to enter the foot behind the medial malleolus, which is often referred to as the tarsal tunnel. So the muscles of the superficial posterior compartment are collectively called the calf muscles, namely the gastrocnemius, soleus, and plantaris. Collectively, the gastrocnemius and soleus make up the three-headed triceps surae, while the plantaris is a small muscle with a short belly and a long tendon that may be absent in up to 10% of people. The superficial muscles form the characteristic calf shape of the posterior leg, and they all insert into the calcaneus of the foot via the calcaneal tendon. The gastrocnemius is the most superficial muscle in the posterior compartment and forms the proximal and most prominent part of the calf. It has a medial head, which originates from the popliteal surface of the femur superior to the medial femoral condyle, and a lateral head, which originates from the lateral aspect of the lateral femoral condyle. As the muscle descends, its fibers converge at the inferior margin of the popliteal fossa, for which they form the infrolateral border and infromedial border. Distally, the belly of the gastrocnemius combines with the soleus to form the calcaneal tendon, better known as the Achilles tendon, which inserts into the posterior surface of the calcaneus. The gastrocnemius is a major plantar flexor of the ankle, and since it also crosses the knee joint, it flexes the knee as well. Next, there's the soleus, which is deep to the gastrocnemius. It's a large muscle named with a proximal attachment in the shape of an inverted U. Specifically, it originates on the posterior aspect of the head of the fibula and posterior surface of the fibula, the soleal line of the tibia, and the tendinous arch extending between these two bony attachments. Fun fact, this tendinous arch of the soleus is where the popliteal artery and the tibial nerve exit the popliteal fossa. It's also where the popliteal artery bifurcates into its terminal branches, the anterior and posterior tibial arteries. So there's a lot going on there. When the knee is extended, the soleus acts with the gastrocnemius and causes plantar flexion of the ankle. When the knee is flexed, the gastrocnemius is not in tension, and the soleus causes plantar flexion all by itself. So long story short, if you want to work out your gastrocnemius muscles, do standing calf raises, and if you want to work out your soleus muscles underneath, do seated calf raises. And finally, the plantaris originates from the lateral supracondylar line of the femur and the oblique popliteal ligament, descends medially, and condenses into a tendon that runs down the leg between the gastrocnemius and soleus. And just like its two much larger brothers, its tendon blends with the calcaneal tendon. This mysterious muscle acts in tandem with the gastrocnemius, but due to its size, its function outside of proprioception is insignificant. And now for the four deep muscles of the posterior compartment, namely the popliteus, flexor digitorum longus, flexor hallucis longus, and tibialis posterior. First, the popliteus is a thin triangular muscle that forms the inferior part of the floor of the popliteal fossa. It originates on the lateral aspect of the lateral femoral condyle and the posterior horn of the lateral meniscus. From there, it runs infromedially towards the tibia and inserts on the posterior surface of the tibia above the soleal line. The popliteus unlocks the locked knee from a standing position to a flex position by rotating the femur laterally during initial stages of flexion of the knee. Next, flexor hallucis longus originates from the posterior surface of the inferior two-thirds of the fibula and inferior part of the interosseous membrane, descends inferiorly from the posterolateral to the posteromedial side of the leg, and passes posterior to the medial malleolus towards the sole of the foot. Ultimately, it inserts at the base of the distal phalanx of the great toe. The flexor hallucis longus muscle flexes all of the joints of the great toe in addition to weak plantar flexion of the ankle. Third, the flexor digitorum longus is smaller than the other flexors. It originates from the medial part of the posterior surface of the tibia inferior to the soleal line and descends the medial aspect of the posterior leg. It then passes diagonally posterior to the medial malleolus into the sole of the foot, crossing the tendon of the flexor hallucis longus superficially on its way. After it crosses the flexor hallucis longus tendon, the flexor digitorum longus divides into four tendons and inserts into the base of the distal phalanges of the lateral four digits. This muscle flexes the lateral four digits and helps with plantar flexion of the ankle. And finally, the tibialis posterior is the deepest muscle in the posterior compartment, and it lies between the two flexors in the same plane as the tibia and fibula. It originates from the interosseous membrane and the adjacent posterior surfaces of the tibia and fibula, and it descends down the leg between the two muscles until it passes posterior to the medial malleolus and reaches the calcaneus deep to the two flexor tendons. The tibialis posterior inserts into the tuberosity of the navicular bone, cuneiforms, cuboid, and sustentaculum tali of the calcaneus, along with the bases of the second, third, and fourth metatarsals. Its main job is to work with the tibialis anterior to produce inversion, and it also helps with plantar flexion of the ankle. Finally, it also supports or maintains the medial longitudinal arch of the foot during weight bearing. You've probably noticed a common theme to these three deep subcompartment muscles as they enter the foot, and that is that they pass posterior to the medial malleolus in what is called the tarsal tunnel. This is a great anatomical landmark to help distinguish the muscular tendons and neurovascular structures of the posterior compartment as they travel into the foot. From anterior to posterior, the structures can be identified using the mnemonic Tom, Dick, and Nervous Harry. The first and most anterior structure passing behind the medial malleolus is the tibialis posterior, then the flexor digitorum longus, followed by the posterior tibial artery, then the tibial nerve, and finally the flexor hallucis longus. Speaking of nerves, the tibial nerve is the most important as it innervates all the muscles in the posterior compartment. The tibial nerve is the larger of the two terminal branches of the sciatic nerve. It runs vertically through the popliteal fossa with the popliteal artery passing between the heads of the gastrocnemius deep to the tendinous arch of the soleus. At the ankle, the nerve lies between the tendons of the flexor hallucis longus and flexor digitorum longus, and after traveling deep to the flexor retinaculum, the tibial nerve divides into the medial and lateral plantar nerves. Switching to arteries, the posterior tibial artery provides the blood supply to the posterior compartment of the leg and the foot. It's the larger and more direct terminal branch of the popliteal artery. It begins at the distal border of the popliteus as the popliteal artery passes deep to the tendinous arch of the soleus and simultaneously bifurcates into the anterior and posterior tibial arteries. The posterior tibial artery is accompanied by the tibial nerve and veins, and it runs posterior to the medial malleolus as described previously. Deep to the flexor retinaculum, the posterior tibial artery divides into medial and lateral plantar arteries, the arteries of the sole of the foot. Finally, there's the fibular artery, the largest and most important branch of the posterior tibial artery. It arises inferior to the distal border of the popliteus and the tendinous arch of the soleus, and it descends obliquely toward the fibula, running down the medial side of the fibula parallel to the posterior tibial artery within the deep compartment. The fibular artery gives rise to the nutrient artery of the fibula, the largest nutrient artery in the body. It also gives off numerous muscular branches to both the posterior compartment and lateral compartment of the leg. Distally, the fibular artery also contributes branches to the periarticular anastomosis of the ankle. Okay, fantastic job, you've made it till the end. Before we recap, let's see if you can remember the components of the posterior compartment of the leg. Alright, as a quick recap. The leg is organized into 3 fascial compartments. The anterior compartment is bound posteriorly by the interosseous membrane, medially by the tibia, and laterally by the fibula and anterior intermuscular septum. Anteriorly, it's bound by the deep fascia of the leg and skin. Inferiorly, the deep fascia forms the superior extensor retinaculum and the inferior extensor retinaculum. The anterior compartment contains the muscles tibialis anterior, the extensor digitorum longus, the extensor hallucis longus, and the fibularis tertius. The lateral compartment of the leg contains the muscles fibularis longus and fibularis brevis, which are responsible for eversion of the foot and plantar flexion at the ankle. The posterior compartment of the leg is divided into a superficial and deep subcompartment by the transverse intermuscular septum. The superficial muscles are the gastrocnemius, soleus, and plantaris. They all produce the action of plantar flexion at the ankle. These muscles also form the calf shape of the posterior leg, and they all insert into the calcaneus of the foot via the calcaneal or Achilles tendon. The deep muscles are represented by the popliteus, flexor digitorum longus, flexor hallucis longus, and tibialis posterior. To remember the structures of the posterior compartment passing posterior to the medial malleolus, we can use the mnemonic Tom, Dick, and Nervous Harry, representing from anterior to posterior the tibialis posterior, flexor digitorum longus, the posterior tibial artery, the tibial nerve, and the flexor hallucis longus.
The popliteal fossa is the space behind your knee, and even though it may not look like much from the outside, it's actually a complex region delimited by muscles and fascia, and it contains a lot of vessels and nerves that pass from the thigh to the leg. So first, let's look at the popliteal fossa, which superficially resembles a diamond-shaped cavity when the knee is slightly flexed. This means the popliteal fossa has 2 superior borders and 2 inferior borders. So let's go over those borders. The 2 superior ones are the superolateral border, delimited by the biceps femoris, and the superomedial border, delimited by the semimembranosus and semitendinosus muscles. The two inferior borders are the inferomedial border, represented by the medial head of the gastrocnemius muscle, and the inferolateral border, delimited by the lateral head of the gastrocnemius muscle. The popliteal fossa also has a floor and a roof. The roof consists of two layers, the popliteal fascia and skin. However, things get a bit more complicated with the floor, which has three sections: the bony popliteal surface of the femur superiorly, the posterior aspect of the joint capsule of the knee joint centrally, and the popliteus muscle and fascia covering the popliteus muscle inferiorly. The popliteal fossa contains the small saphenous vein, the posterior cutaneous nerve of the thigh, the sciatic nerve, which divides into the tibial and common fibular nerves at the superior border, the popliteal arteries and veins along with their branches and tributaries, and the popliteal lymph nodes and lymphatic vessels. Okay, so now let's dive in with a little more detail, layer by layer. First, there's the subcutaneous or superficial fascia, which contains the small saphenous vein, the terminal branch of the posterior cutaneous nerve of the thigh, and the medial and lateral sural cutaneous nerves. Then comes the deep fascia, also called the popliteal fascia, which covers and protects the neurovascular structures within the popliteal fossa. Next, there are the neurovascular structures that traverse the popliteal fossa to pass from the thigh to the leg. When dissecting from superficial to deep within the fossa, first are the nerves, then the veins, and finally the arteries, which lie deep, directly on top of the floor of the fossa. So let's get started with the nerves. You might have already heard about the sciatic nerve, which begins in the lower part of the sacral plexus and ends at the superior angle of the popliteal fossa, where it divides into the tibial and common fibular nerves. The tibial nerve is the medial and larger terminal branch, and it derives from the anterior divisions of the anterior rami of the L4 to S3 spinal nerves. From its origin at the apex of the popliteal fossa, it divides the fossa into two equal parts as it passes from its superior to its inferior angle. Within the fossa, it gives muscular branches to the soleus, gastrocnemius, plantaris, and popliteus muscles. The tibial nerve eventually passes deep to the plantaris and gastrocnemius muscles at the inferior border of the popliteal fossa. Then, it enters the foot beneath the flexor retinaculum and finally divides into the medial and lateral plantar nerves. The tibial nerve also gives off the medial sural cutaneous branch that contributes to the sural nerve. The sural nerve mainly provides cutaneous innervation for the leg. Now let's look at the common fibular nerve, which is the lateral terminal branch of the sciatic nerve, and derives from the posterior divisions of the anterior rami of the L4 to S2 spinal nerves. It begins in the same place as the tibial nerve, and it follows closely to the medial border of the biceps femoris and its tendon along the superolateral boundary of the fossa. It then leaves the fossa, passing superficial to the lateral head of the gastrocnemius. It reaches the posterior aspect of the head of the fibula, where it winds around the fibular neck and divides into its terminal branches, the deep and superficial fibular nerves. It also gives off a branch called the lateral sural cutaneous nerve, which contributes to forming the sural nerve. After the sural nerve receives branches from both the tibial and common fibular nerve, it descends between the two heads of the gastrocnemius and becomes superficial in the middle leg. It then descends with the small saphenous vein and passes inferior to the lateral malleolus to reach the lateral part of the foot. Ultimately, the sural nerve supplies the posterior and lateral part of the inferior third of the leg, and the lateral side of the foot. Next up, let's look at the arteries of the popliteal fossa. And the starring role for this short movie belongs to the popliteal artery. This artery continues the femoral artery after it passes through the adductor hiatus. The popliteal artery is the deepest structure in the popliteal fossa, and it crosses it inferolaterally and ends at the inferior border of the popliteus, where it divides into the anterior tibial artery, which supplies the anterior compartment of the leg, and the posterior tibial artery, which supplies the lateral and posterior compartments. The popliteal artery also gives off branches to the hamstrings, gastrocnemius, soleus, and plantaris muscles. Okay, so the popliteal artery also sends 5 branches that supply the capsule and ligaments of the knee joint: the superior lateral, superior medial, middle, inferior lateral, and inferior medial genicular arteries. These form the periarticular genicular anastomosis, a network of vessels surrounding the knee that provides collateral circulation when the popliteal artery is compressed or blood flow is reduced. Other arteries also contribute to the genicular anastomosis. For example, supromedially, there's the descending genicular branch of the femoral artery. Suprolaterally, there's the descending branch of the lateral femoral circumflex artery. And infralaterally, there's the anterior tibial recurrent artery, a branch of the anterior tibial artery. Moving on, there are the veins. The popliteal vein begins at the distal border of the popliteus as a continuation of the posterior tibial vein. It ascends and becomes superficial in the same fibrous sheath as the popliteal artery, but it lies superficial to the artery. The popliteal vein terminates at the adductor hiatus, which is an osteoaponeurotic opening in the adductor magnus at the junction of the middle 1/3 and lower 1/3 of the thigh. After traversing the hiatus, it becomes the femoral vein. Now, there are also several veins that drain into this structure. The most important ones are the veins corresponding to the branches of the popliteal artery and the small saphenous vein, which passes from the posterior aspect of the lateral malleolus to the popliteal fossa, where it pierces the deep popliteal fascia and enters the popliteal vein. And finally, lymphatic drainage is divided into superficial and deep lymph nodes. Superficial popliteal lymph nodes are typically small and are found in the subcutaneous tissue. The deep popliteal lymph nodes, on the other hand, surround the popliteal vessels and receive lymph from the joint capsule and the lymphatic vessels that accompany the deep veins of the leg. These lymphatic vessels and nodes then follow the femoral vessels to the deep inguinal lymph nodes. Okay, now before we wrap up, let's see if you can identify the contents of the popliteal fossa. Alright, as a quick recap, the popliteal fossa is bounded superolaterally by the biceps femoris, superomedially by the semimembranosus and semitendinosus muscles, and infralaterally and infromedially it is bounded by the lateral and medial heads of the gastrocnemius. The roof is made of the popliteal fascia and skin, whereas the floor is made by the popliteal surface of the femur superiorly, the posterior aspect of the knee joint capsule centrally, and the popliteal surface fascia inferiorly. The fossa also contains structures like the sciatic nerve, the tibial nerve, the common fibular nerve, and the sural nerve, which ultimately supplies the posterior and lateral side of the leg and the lateral side of the foot. The deepest neurovascular structure is the popliteal artery, which continues the femoral artery after it passes through the adductor hiatus. Then there's the popliteal vein, a continuation of the posterior tibial vein that terminates at the adductor hiatus, where it becomes the femoral vein. Finally, the popliteal fossa has superficial lymph nodes in the subcutaneous tissue and deep nodes around the popliteal vessels.
Now, everyone knows about the famous hip joint and knee joint, but not many people like to talk about the lesser known tibiofibular joints. The tibiofibular joints are two joints of the leg, one superior and one inferior. This doesn't mean one is better than the other, just that one is lower down. Right below the knee joint, there are the leg bones, namely the tibia and fibula, which are connected by a superior tibiofibular joint and an inferior tibiofibular joint, which is a component of the distal tibiofibular syndesmosis, as it is the distal end of the syndesmotic or fibrous connection between the tibia and fibula. These joints have minimal function in terms of movement, but play a greater role in stability and weight bearing. The superior tibiofibular joint is a plane type of synovial joint, which allows the involved bones to glide over one another to create movement. This joint is located between the flat articular facet on the fibular head and a similar articular facet situated posterolaterally on the lateral tibial condyle. As expected, the superior tibiofibular joint is also surrounded by a joint capsule which attaches to the margins of the articular surfaces of the fibula and tibia. This joint allows slight gliding movement during dorsiflexion of the foot. The tibiofibular syndesmosis, on the other hand, is a compound fibrous joint. Basically, it represents the fibrous union of the tibia and fibula by means of the interosseous membrane, which unites the shaft of the bones, and the anterior tibiofibular joint, which unites the distal ends of the bones. Speaking of which, the inferior tibiofibular joint, or distal tibiofibular syndesmosis, occurs at the distal ends of the bones where the rough triangular medial surface of the fibula articulates with the fibular notch of the tibia. But remember, as a fibrous joint, there is no joint cavity. Instead, the bones are held together by strong tibiofibular ligaments. The deep interosseous tibiofibular ligament, which is continuous superiorly with the interosseous membrane, forms the strongest connection between the tibia and fibula. The joint is also strengthened anteriorly by the anterior tibiofibular ligament and posteriorly by the posterior tibiofibular ligament. Finally, the inferior transverse ligament is the deep distal continuation of the posterior tibiofibular ligament and forms a strong connection between the two malleoli. This joint plays an important role in stabilizing the ankle joint because it keeps the lateral malleolus firmly against the lateral surface of the talus. This joint allows only a small amount of movement to accommodate the upward wedging motion of the talus during dorsiflexion of the foot. Okay, as a quick recap, the superior tibiofibular joint is a plane type of synovial joint located between the flat facet on the fibular head and a similar articular facet situated posterolaterally on the lateral tibial condyle. The tibiofibular syndesmosis is a compound fibrous joint formed by the union of the tibia and fibula by means of the interosseous membrane, which unites the shaft of the bones, and the inferior tibiofibular joint, consisting of the anterior, interosseous, and posterior tibiofibular ligaments, which unite the distal ends of the bones.
The foot bone's connected to the leg bone's connected to the thigh bone. Alright, as a quick recap, just kidding. The lower limbs actually have an incredibly detail-rich skeleton that can be divided into two functional components: the pelvic girdle, which connects the lower limb to the axial skeleton, and the bones of the free lower limb. The pelvic girdle is a bony ring known as the pelvic ring, consisting of the right and left hip bones, and the sacrum, which is common to both the pelvic girdle and the axial skeleton. Each hip bone consists of the ilium, ischium, and pubic bone, and has three articulations. Posteromedially, it articulates with the sacrum at the sacroiliac joint. Anteromedially, it articulates with the other hip bone at the pubic symphysis. And finally, it articulates with the head of the femur to form the hip joint. Okay, so the ilium is the largest and most superior part of the hip bone, and it can be divided into a body and a wing. The wing, or ala, of the ilium has a lateral and a medial surface, a crest, and two borders, anterior and posterior. Superiorly, there's the iliac crest, which begins at the anterior superior iliac spine, and it extends posteriorly to the posterior superior iliac spine. The crest has an internal and external lip, and serves as an important attachment site for muscles and deep fascia. Next, the lateral surface of the ala has three rough arched lines, called the posterior, anterior, and inferior gluteal lines, where the gluteal muscles attach. These are the muscles of your bottom. Next, the medial surface can be divided into two by the internal lip of the iliac crest. The anterior portion is concave, and it forms the iliac fossa, which is where the iliacus muscle attaches. The posteromedial portion is rough, and it presents the auricular surface, which is shaped like an ear, and articulates with an identical surface on the sacrum to form the sacroiliac joint. Next, the anterior border presents the anterior superior iliac spine superiorly, where the inguinal ligament and the sartorius muscle attach. And underneath it, there's the anterior inferior iliac spine, where the straight head of the rectus femoris muscle and the iliofemoral ligament of the hip joint attach. Finally, the posterior border has a posterior superior iliac spine, which is where the oblique portion of the posterior sacroiliac ligaments and the multifidus muscle attach. Underneath it, there's a posterior inferior iliac spine, below which is a deep notch, the greater sciatic notch. Okay, so the ala continues inferiorly with the body of the ilium, which joins the pubis and ischium to form the acetabulum. Next, let's look at the ischium, which forms the postero-inferior part of the hip bone. The posterior border of the ischium forms the inferior margin of the greater sciatic notch. At the end of the notch, there's a triangular surface called the ischial spine, where the sacrospinous ligament and the superior gemellus muscle originates. Below the spine, there's the lesser sciatic notch, which is separated from the greater sciatic notch by the sharp demarcation of the sacrospinous ligament. Going even further down, the body of the ischium has an ischial tuberosity, which is a thick, rough prominence that supports our weight while sitting, and where the inferior gemellus muscle and the hamstrings attach. Unfortunately, these aren't actual hamstrings, but rather a pair of three posterior thigh muscles. Anteriorly, the ramus of the ischium joins the inferior ramus of the pubis to form a bar of bone called the ischiopubic ramus that represents the inferior border of the obturator foramen. Okay, now finally there's the pubis, which forms the anterior-medial part of the hip bone. The body of the pubis has a symphyseal surface on its medial surface, which articulates with an identical surface on the body of the contralateral pubis via the pubic symphysis. The pubic symphysis is a cartilaginous joint that sits between and joins the pubic bones at their respective rami. Anterosuperiorly, the body presents a rounded thickening called the pubic crest, which is where the abdominal muscles attach. The crest extends laterally as a pubic tubercle, which is the distal attachment point of the inguinal ligament. Superior and laterally, the body of the pubis continues with its superior ramus, which forms part of the acetabulum. The lateral part of the superior ramus also has a sharp raised edge, the pectineal line, or pecten pubis, which joins the arcuate line of the ilium to form the iliopectineal line. Inferiorly and laterally, the pubis presents the inferior ramus, which joins the ramus of the ischium to form the ischiopubic ramus. Now that we know a bit about the bones separately, let's talk about what they form together. First, there's the acetabulum, which is a large socket of the lateral face of the hip bone that articulates with the head of the femur to form the hip joint. Each of the three primary bones contributes to the acetabulum as follows. The ischium provides the posterior-inferior boundary, the ilium forms the upper boundary, and the rest, near the midline, is formed by the pubis. The margin of the acetabulum is incomplete inferiorly, where the acetabular notch is situated, and makes it look like a cup with a broken rim. There's also a rough depression in the floor of the acetabulum, the acetabular fossa, right above the acetabular notch. These two structures, the acetabular notch and depression, are surrounded by the thick and smooth lunate surface of the acetabulum, the articular surface on which the head of the femur slides. Moving on, there's a large oval opening of the hip bone called the obturator foramen, bounded by the pubis, ischium, and the rami. Normally, the obturator foramen is closed by the very strong obturator membrane, which has a tiny passageway for the obturator nerve and vessels called the obturator canal. The purpose of this foramen is to minimize bone weight, while its closure by the obturator membrane provides an extensive area for the fleshy attachment of internal and external obturator muscles. Okay, so that was enough info to make your hip bones crack. So why don't you pause for a minute and see if you can label the most important features of the hip bones before we move on. Okay, great. Let's now move on to the bones of the free lower limb, which includes the femur, tibia, fibula, patella, and the bones of the feet. Now, the femur is the longest bone in the body and looks like the letter L turned upside down, making them oblique and directed inferior-medially as the femur progresses distally. To place it in its anatomical position, the head of the femur, which is the part with a round prominence proximally, should be situated superiorly and medially. Its distal part, the bit with the two round prominences, is situated inferiorly and a bit more medial than the superior part, because the femur has an oblique position in the body. And finally, on the posterior part of the bone, there's a sharp longitudinal line, the linea aspera. The head of the femur articulates with the acetabulum to form the hip joint, while the distal femur articulates with the tibia and patella, known as the kneecap, to form the knee joint. The femur's main purpose is to transmit body weight from the hip bone to the tibia when a person is standing, and, at the same time, to provide attachment for 23 muscles. Okay, so the proximal femur has a head, neck, and the greater and lesser trochanters. The round head of the femur makes up about 2/3 of a sphere, and is covered in articular cartilage, except for a medially placed depression, which creates a pit called the fovea capitis, which is where the ligament of the head of the femur attaches. The neck of the bone is trapezoidal, with its narrow end supporting the head and its broader base continuous with the shaft of the femur. Now, at the junction between the femoral neck and shaft, there are two large bumps called trochanters. The lesser trochanter is situated medial and inferior to the junction, and is where the iliopsoas attaches. Lateral and superior to the junction is the much larger, greater trochanter, where the abductor and rotator muscles of the thigh attach. At the base of the greater trochanter, there's a deep depression called the trochanteric fossa, which is where the tendon of the obturator externus muscle, obturator internus, and the superior-inferior gemellus all insert. Now, running from the greater to lesser trochanter, there's also the intertrochanteric line on the anterior side of the proximal femur, which is where the neck of the femur and femoral shaft join. The iliofemoral ligament, considered the strongest of the human body, attaches above this line, while the upper part of the vastus medialis attaches to the lower part of the intertrochanteric line. Posterior to the trochanters, there's a similar but smoother and more prominent ridge, the intertrochanteric crest, which in turn has a rounded elevation on its upper side called the quadrate tubercle, and the quadratus femoris muscle inserts on both these elements. Most of the femoral shaft is smoothly rounded, and it provides fleshy origin to extensors of the knee. The exception is a posterior, longitudinal, rough line called the linea aspera, which is where the aponeuroses of the thigh adductor muscles attach. The linea aspera is situated around the middle third of the femoral shaft, and it presents a medial and lateral lip and an intermediate ridge. Superiorly, the lateral lip blends with a broad, rough patch of bone called the gluteal tuberosity, which is where part of the gluteus maximus attaches. The medial lip, on the other hand, continues superiorly as a spiral line, which extends towards the lesser trochanter and then passes to the anterior surface of the femur, where it continues with the intertrochanteric line. The intermediate ridge is called the pectineal line, and it extends from the central part of the linea aspera to the base of the lesser trochanter. Switching to its inferior part, here, the linea aspera divides into a medial and lateral supracondylar lines, which lead you to, you've guessed it, the medial and lateral femoral condyles. Speaking of which, let's look at the distal femur, which consists almost entirely of two round prominences called the medial and lateral femoral condyles. The femoral condyles articulate with the menisci, which are two plates of cartilage on top of the tibia, and with the tibial condyles to form the knee joint. The femoral shaft sits in about 9 degrees of valgus positioning from the vertical plane, which compensates for the oblique nature of the femur and allows the femoral condyles to be on the same horizontal level when articulating with the tibia. The lateral surface of the lateral condyle has a central projection called the lateral epicondyle, whereas the medial surface of the medial condyle has a medial epicondyle. The condyles are separated posteriorly and inferiorly by the intercondylar fossa, but they merge anteriorly, forming a shallow longitudinal depression called the patellar surface, which articulates with the patella. The epicondyles are where the medial and lateral collateral ligaments of the knee joint attach proximally. Superior to the medial epicondyle, there's another elevation, unsurprisingly called the adductor tubercle, where part of the adductor magnus muscle inserts. Okay, so that was enough info to make you fall on your knees. Why don't you pause for a minute and see if you can label the most important features of the femur before we move on. Ready? Okay, so the patella or kneecap is a triangular bone located on top and in the middle of the femoral condyles. It has an anterior and a posterior surface, a superior base, and an inferior apex, and 2 margins. The anterior surface is smooth, and you can actually feel it on the anterior part of your knee. The posterior surface is covered with a thick layer of articular cartilage, so it can articulate with the patellar surface of the femur. This surface is divided by a vertical ridge into a narrower medial and wider lateral articular surface. The ridge, along with the balanced pull of the vastus muscles, helps keep the patella centered in the intercondylar groove as it articulates with the femur during flexion and extension. The patella acts as the largest sesamoid bone in the body and functions to provide leverage for the quadriceps during extension. And that was a breeze, wasn't it? Let's move on to the second largest bone of the body, the tibia, which is located on the anterior medial side of the leg, nearly parallel to the fibula. This bone kind of resembles a scepter, so the thicker and flat proximal end is superior, and its thinner and rounder distal end is situated inferiorly. And because the body of the tibia is somewhat triangular, the tip of the triangle should be anterior, while its base should be posterior. The tibia articulates with the condyles of the femur proximally, and the talus distally, so it transmits the body's weight to the foot, and it provides stability to the ankle joint. The tibia can be divided into a proximal and distal end and a shaft. Okay, so the proximal tibia resembles half a pyramid turned upside down. Superiorly, the base of the pyramid is rather flat, so it's called the tibial plateau. This plateau has medial and lateral articular surfaces that articulate with the condyles of the femur. The articular surfaces are separated by an intercondylar eminence, formed by 2 raised ridges of bone, the medial and lateral intercondylar tubercles, which are flanked by the anterior intercondylar area to the front and posterior intercondylar area to the back. The intercondylar eminence fits into the intercondylar fossa between the femoral condyles, and it's where the menisci and principal ligaments of the knee attach. Moving on, underneath the base of the tibia, there are 2 prominences called the tibial condyles. The lateral tibial condyle is situated on the anterior, lateral, and posterior side of the proximal tibia. On the anterior surface of the lateral tibial condyle, there's Gerdy's tubercle, which is where the iliotibial tract attaches distally. The lateral condyle also presents a fibular articular facet for the head of the fibula on its posterior lateral surface. The medial condyle, situated on the anterior, medial, and posterior side of the proximal tibia, is where the semimembranous muscle inserts. Moving on, the shaft of the tibia has three borders: anterior, medial, and lateral, or interosseous, and three surfaces: medial, lateral, and posterior. The anterior border of the tibia is the biggest, and you can feel it under your skin throughout its length. At the superior end of the anterior border, there's a tibial tuberosity, which is where the patellar ligament attaches distally. Next, the lateral border is also known as the interosseous border, and it's where the interosseous membrane attaches to connect the tibia and fibula. The medial surface of the tibia is subcutaneous as well, and together with the anterior border, they're collectively known as a shin. The posterior surface is marked by a rigid bone known as the soleal line, which is where the popliteus muscle and its fascia attach, and tibialis posterior, flexor digitorum longus, and soleus muscles also originate here. Distal to the soleal line, there's a nutrient foramen, an opening in the bone that gives passage to the main artery supplying the proximal end of the bone and its marrow. Finally, the distal tibia is longer on the medial side, a bit like a claw, and it forms the medial malleolus. The inferior surface of the shaft and the lateral surface of the medial malleolus articulate with the talus, a bone of the foot. On the lateral side of the distal tibia, the sharp border of the interosseous border is replaced by the fibular notch, where the fibula attaches to form the tibiofibular joint. Alright, now the slender fibula lies posterior-lateral to the tibia. The fibula articulates superiorly with the fibular facet on the lateral tibial condyle, and together they form the proximal tibiofibular joint. Inferiorly, it articulates with the fibular notch of the tibia to form the distal tibiofibular joint. It also articulates with the talus to form the superior part of the ankle joint. The fibula has no function in weight bearing, and it serves mainly for muscle attachment. It can be divided into a distal end, a proximal end, and a shaft. The proximal end has an enlarged head with a small neck inferior to it. The head has a pointed peak on top of it called the apex, and it articulates with the fibular facet on the posterior-lateral inferior surface of the tibial condyle. The shaft is twisted and provides many sites of muscular attachments. Similar to the shaft of the tibia, it's triangular, having three borders, anterior, interosseous, and posterior, and three surfaces, medial, posterior, and lateral. The distal end enlarges and extends laterally and inferiorly to form the lateral malleolus. The lateral malleolus is more prominent and posterior than the medial malleolus on the tibia, and it extends approximately 1 centimeter more distally to form part of the ankle joint and help you locate furniture in the dark. Ow! Absolutely fabulous! We're done with 2 more bones. Before we move on to the bones of the foot, take a rest and try and recognize the main parts of the tibia and fibula. Whew! We've reached the foot! The foot can be divided into 3 parts: the tarsus, metatarsus, and phalanges. First up, the tarsus makes up the posterior part of the foot, and it consists of 7 bones. The talus is the most superior bone of the foot, and the only one that articulates with the leg bone superiorly at the ankle joint. Inferiorly, it articulates with the calcaneus to form the subtalar joint, and anteriorly, it articulates with the navicular at the talonavicular joint. Overall, it has a head that faces anteriorly, where it articulates with the navicular bone, and it also has a rough neck and a body, which is placed posteriorly. The superior surface of the body, or trochlea of the talus, is gripped medially and laterally by the 2 malleoli. Finally, the body of the talus narrows posteriorly and inferiorly and forms the posterior process of the talus. The process has a groove for the tendon of flexor hallucis longus, and is flanked by a prominent lateral tubercle and a less prominent medial tubercle. Second up in the tarsus, the calcaneus, is the bone that makes up your heel, and it sits right underneath the talus. The calcaneus articulates superiorly with the talus at the subtalar joint and anteriorly with the cuboid to form the calcaneo-cuboid joint. Its most important landmark is the fibular trochlea, an oblique ridge on its lateral surface, which anchors a tendon for the everters of the foot, the muscles which move the sole of the foot outward. There's also a weight-bearing landmark on the posterior-inferior part of the calcaneus called the calcaneal tuberosity, casually called the heel, which is the medial, lateral, and anterior tubercles. And finally, projecting from the medial surface of the calcaneus, there's a shelf-like support for the head of the talus called the sustentaculum tali, which provides attachment not for books, but for ligaments and muscles. Third, the navicular is a flattened, boat-shaped bone which articulates interiorly with the three cuneiforms, and posteriorly with the head of the talus. Something to know is that its medial surface projects inferiorly to form the navicular tuberosity, which is where most of the tendon of the tibialis posterior muscle attaches. Fourth, the cuboid is a cubical bone, as expected, and it's the most lateral bone in the distal row of the tarsus. This means it has 6 surfaces: anterior, posterior, dorsal, plantar, medial, and lateral, most of which articulate with other bones of the foot. Its most important landmarks are the tuberosity of the cuboid, and on the inferior lateral surface there's a groove for the fibularis longus, or peroneus longus muscle tendon. The last 3 bones of the tarsus are the wedge-shaped cuneiform bones. The medial cuneiform is the first and largest bone. The intermediate cuneiform is the smallest of the bunch, and the third and final bone is the lateral cuneiform, which is the only one to articulate with the cuboid. Each cuneiform articulates posteriorly with the navicular bone, and anteriorly with the base of its corresponding metatarsal. So let's look at the metatarsus now, which comprises of 5 metatarsal bones, all of which articulate with the tarsal bones proximately to form the tarsometatarsal joints. Distally, they articulate with the proximal phalanges, or the bones that make up the toes. They're numbered from the medial side of the foot, and each metatarsal has a large base proximally, a shaft, and a narrow head distally. Some rather fun facts about them include the fact that the bases of the 1st and 5th metatarsals have large tuberosities for tendon attachment, and that the tuberosity of the 5th metatarsal projects laterally over the cuboid. And finally, on the plantar surface of the head of the 1st metatarsal, there are 2 miniature bones, the medial and lateral sesamoid bones, and they're embedded in the tendons passing along the plantar surface. And finally, we've reached the 14 phalanges. Each toe, except for the first, or great toe, has a proximal, middle, and distal phalange, while the first toe has only a proximal and distal phalange. And each phalanx has a proximal base, a shaft, and a distal head. Phew, alright, as a quick recap. The hip bones are formed by the fusion of 3 primary bones, the ilium, ischium, and pubis. The ilium is the superior part of the bone. The ischium forms the posterior-inferior part of the hip bone. The pubis forms the anterior-medial part of the hip bone. The femur's proximal end consists of the femoral head and the greater and lesser trochanters. There's also the intertrochanteric line on the anterior side of the proximal femur, and conversely, posterior to the trochanters, the intertrochanteric crest. The shaft of the femur features the linea aspera on its posterior side, while the distal femur consists almost entirely of the medial and lateral femoral condyles. The tibia is located on the anterior-medial side of the leg. The proximal tibia comes with the tibial plateau, which has 2 articular surfaces divided by the intercondylar eminence, and distal to the plateau are the tibial condyles. The tibial shaft has a tibial tuberosity, and the interosseous border for the interosseous membrane, inferior to which we can find the fibular notch. On the posterior tibia there's a soleal line, and the distal tibia has a claw medially, the medial malleolus. The fibula lies posterior-lateral to the tibia. Its proximal end has a large head superior to a small neck, and a pointed peak where the articular surface for the fibular facet lies. The distal end of the fibula extends laterally and inferiorly to form the lateral malleolus. Finally, the foot comprises of the tarsus, metatarsus, and phalanges. The tarsus is made up of the talus superiorly, the calcaneus, right underneath the talus, and the navicular, which sits directly in front of the calcaneus, the cuboid, which also sits in front of the talus, and the 3 cuneiform bones. The metatarsus has 5 metatarsal bones, and finally, there are 14 phalanges that make up the bones in the toes. The first digit, or great toe, has 2 phalanges, proximal and distal. The other 4 digits have 3 phalanges each, proximal, middle, and distal, respectively.
Now, I'm sure some of us can agree that we love rock and roll. However, most of us can also agree that we don't love it when we step on a rock and roll our ankles. Okay, how's that for a segue into talking about the ankle? Pretty good? All right, enough of the bad opening lines. Let's talk about the joints of the ankle and the foot. The ankle joint, or tibio-talar joint, is a hinge-type synovial joint located between the distal ends of the tibia and the fibula and the superior part of the talus, which are the 3 main bones of this joint. The main articular components of this joint are the trochlea and the body of the talus, which articulates medially with the medial malleolus of the tibia and laterally with the lateral malleolus of the fibula. In a nutshell, the tibia and the fibula are bound together by the strong tibiofibular ligaments, and together their respective malleoli form a bracket-shaped socket which is covered in hyaline cartilage. This socket is known as the malleolar mortis and is where the pulley-shaped trochlea of the talus fits. The malleolar mortis is bounded posteriorly by the inferior part of the posterior tibiofibular ligament, superiorly by the articular surface of the tibia, with the medial and lateral walls being the medial malleolus and lateral malleolus respectively. The joint capsule of the ankle joint is thin anteriorly and posteriorly, but is supported on each side by a series of strong ligaments. Its fibrous layer is attached superiorly to the borders of the articular surfaces of the tibia and the malleoli, and inferiorly to the talus. By contrast, its synovial layer is loose and lines the fibrous layer of the capsule. Now, the supportive ligaments reinforce the ankle joint. Laterally, there's the lateral ligament of the ankle consisting of 3 completely separate ligaments which help prevent inversion of the ankle. First, there's the anterior talofibular ligament that extends anteromedially from the lateral malleolus to the neck of the talus. Second, there's the posterior talofibular ligament which runs horizontally, medially, and posteriorly from the malleolar fossa to the lateral tubercle of the talus. And third, there's the calcaneofibular ligament, which passes postero-inferiorly from the tip of the lateral malleolus to the lateral surface of the calcaneus. And medially, you guessed it, there's the medial ligament of the ankle, also known as the deltoid ligament, which stabilizes the ankle joint during eversion and prevents subluxation of the joint. This ligament attaches proximally to the medial malleolus, from where it fans out, attaching distally to the talus, calcaneus, and navicular via 4 adjacent and continuous parts: the tibionavicular part, the tibiocalcaneal part, and the anterior and posterior tibiotalar parts. The main movements of the ankle joint are dorsiflexion and plantarflexion. Dorsiflexion of the ankle is produced by the muscles in the anterior compartment of the leg, and namely the tibialis anterior, extensor digitorum longus, and extensor hallucis longus. Plantarflexion of the ankle is produced by the muscles in the posterior compartment of the leg, including the gastrocnemius and soleus in the superficial subcompartment, as well as the muscles of the deep subcompartment such as tibialis posterior, flexor digitorum longus, and flexor hallucis longus. Now, because the thicker anterior part of the talus is held in the mortise during dorsiflexion, the joint is more stable in dorsiflexion, and less stable during plantar flexion because it's the narrow posterior part of the talus that is held more loosely in the mortise. Finally, the arterial supply of the ankle joint is derived from the malleolar branches of the fibular and anterior and posterior tibial arteries. And nerve supply of the ankle joint derives from the tibial nerve and deep fibular nerve. Okay, now before the joints of the foot kick in, you know the drill. Let's take a break and review the main components of the ankle joint. Okay, so some of the main joints of the foot include the subtalar joint, transverse tarsal joint, other intertarsal joints, tarsometatarsal joints, metatarsophalangeal joints, and interphalangeal joints. Let's start out with the subtalar joint, which can be defined in two ways. First, the anatomical subtalar joint. This joint is a single synovial joint between the slightly concave posterior calcaneal articular surface of the talus and the convex posterior articular facet of the calcaneus. The clinical subtalar joint includes the anatomical subtalar joint, plus the talocalcaneal part of the talocalcaneo-navicular joint, which are separated by the strong interosseous talocalcaneal ligaments that lie in the tarsal sinus. The clinical subtalar joint is used instead of the anatomical subtalar joint description alone to describe the functionality of this joint, because both the subtalar joint and the talocalcaneal part of the talocalcaneo-navicular joint act together, forming a single functional unit. The subtalar joint undergoes inversion, primarily thanks to the tibialis anterior and tibialis posterior muscles, as well as eversion primarily carried out by the fibularis brevis and the fibularis longus. Next, the transverse tarsal joint is a compound joint formed by two separate joints aligned transversely, the talonavicular part of the talocalcaneo-navicular joint and the calcaneo-cuboid joint. At this joint, the midfoot and forefoot rotate as a unit around the hindfoot. Let's take a look at those joints of the midfoot and forefoot. There are intertarsal joints between the other tarsal bones, as well as the tarsometatarsal joints between the tarsal bones and the metatarsals. All of these joints permit slight gliding movements. The metatarsophalangeal joints, which are located between the metatarsals and phalanges, allow for flexion, extension, and some abduction and adduction. Finally, the interphalangeal joints found between the phalanges allow for some flexion and extension, like when you're wiggling your toes. Go ahead, try it now. All right, that's enough, because we need to discuss the major ligaments of the plantar aspect of the foot. First, the plantar calcaneo-navicular ligament, also known as the spring ligament, extends across and fills a gap between the anterior margin of the sustentaculum tali and the inferior margin of the posterior articular surface of the navicular. This ligament supports the head of the talus, transfers weight from the talus, and also aids in maintaining the longitudinal arch of the foot. Then there's the long plantar ligament, which passes from the plantar surface of the calcaneus to the groove of the cuboid, with some of its fibers extending to the bases of the metatarsals. The long plantar ligament is also important in maintaining the longitudinal arch of the foot. And finally, the plantar calcaneo-cuboid ligament, or the short plantar ligament, which extends from the anterior aspect of the inferior surface of the calcaneus to the inferior surface of the cuboid. And, as expected, it's also involved in maintaining the longitudinal arch of the foot. Now, like we've just mentioned a couple times, we've been hinting at something called the arches of the foot, which helps support the numerous joints of the foot through activities like walking, running, and jumping. There are 3 arches on each foot, forming a triangle, with the base of the triangle at the toes and the tip at the heel of the foot. The base is formed by the transverse arch, whereas the 2 sides are formed by the medial longitudinal arch and the lateral longitudinal arch. Because of their shape, the arches are able to act as a spring, bearing the weight of the body and absorbing the shock produced during locomotion. These arches are relatively elastic, so they can be flattened when standing, only to regain their curvature when weight is removed. Okay, so first, the transverse arch of the foot is located in the coronal plane of the foot, and it is formed by the bases of the metatarsals, the cuboid, and the 3 cuneiform bones. Second, the medial longitudinal arch, which between you and me is the more important of the longitudinal arches, is composed of the calcaneus, talus, navicular, 3 cuneiforms, and 3 medial metatarsals. And third, the lateral longitudinal arch, which we still love just as much even if it's not as important, is flatter and rests on the ground during standing, and is made up of the calcaneus, cuboid, and lateral 2 metatarsals. Now, the arches are also supported by 4 successive fibrous layers, which, from superficial to deep, include the plantar aponeurosis, the long plantar ligament, the short plantar ligament, and the spring ligament. Muscles also help maintain the curvature of the arches. For example, the transverse arch receives muscular support from the fibularis longus and tibialis posterior, which help maintain its curvature. The longitudinal arches receive support from flexor hallucis longus and flexor digitorum longus, with the tibialis posterior and tibialis anterior also playing an important role in supporting the higher medial longitudinal arch. And ta-da, we're done. But before we recap, let's try and recognize the joints and arches of the foot. Alright, as a quick recap, the ankle joint is a hinge-type synovial joint located between the distal ends of the tibia and the fibula, and the superior part of the talus, which sits in the malleolar mortis. The joint capsule of the ankle is supported on each side by the lateral and medial ligament of the ankle. Ankle joint movements include dorsiflexion and plantar flexion. The subtalar joint and the transverse tarsal joint are 2 of the major joints of the foot, and are mainly involved in the inversion and eversion of the foot. The most important ligaments of the foot are the plantar calcaneonavicular or spring ligament, the long plantar ligament, and the plantar calcaneocuboid or short plantar ligament. The foot also has 3 bony arches, supported by other fascial layers and muscle tendons.
When looking at the lower limb from the posterior view, there are 2 regions that stand out immediately: the gluteal region and the posterior thigh. Let's start with what's arguably the most popular of the 2, and it's been featured in countless pop songs, the gluteal region. The gluteal region is situated posterior to the pelvis and inferior to the iliac crest. Laterally, it overlies the greater trochanter, and anteriorly, it extends up to the anterior superior iliac spine. It also extends from the iliac crest superiorly to the gluteal fold inferiorly. The gluteal fold is the crease formed by the inferior aspect of the buttocks and the posterior upper thigh. Medially, the region extends to the mid-dorsal line and is called the intergluteal cleft, which is the groove that separates the buttocks from each other. Actually, before we move on, let's review some important landmarks to help you understand this region's anatomy better. First, the posterior sacroiliac ligament is the posterior continuation of the fibrous capsule of the synovial part of the sacroiliac joint, and continues inferiorly with the sacrotuberous ligament. The sacrotuberous ligament goes from the posterior surface of the ilium and the lateral surfaces of the sacrum to the ischial tuberosity. A similar ligament, called the sacrospinous ligament, passes from the lateral surface of the sacrum and the coccyx to the ischial spine. These 2 ligaments convert the greater and lesser sciatic notches into greater and lesser sciatic foramina. Simply put, the greater and lesser sciatic foramina are passageways, or doors, for structures leaving the pelvis and entering the gluteal region and vice versa. The structures passing through the greater sciatic foramen include the piriformis muscle and the structures that leave the pelvis above it, mostly represented by the superior gluteal vessels and nerve, and the structures that leave the pelvis below it, the sciatic nerve, pudendal nerve, and internal pudendal vessels, inferior gluteal nerve and vessels, posterior femoral cutaneous nerve, and the nerves to obturator internus and quadratus femoris. The lesser sciatic foramen, on the other hand, provides passage for structures entering or leaving the perineum, including the tendon and nerve of obturator internus, as well as the pudendal nerve and vessels. Okay, so the gluteal region is mostly considered a large transitional zone between the trunk and the lower limb. The muscles of the gluteal region are organized into two layers: the superficial, containing the three large overlapping gluteus muscles, and the deep layer, consisting of smaller muscles which all have distal attachments on or near the greater trochanter of the femur, providing lateral rotation and stabilization of the femur. Let's start superficially and talk about one of the most well-known muscles in the body. The gluteus maximus is the most superficial of the bunch, and it's also the largest and the heaviest muscle of the body. Quite the overachiever. More importantly, it originates posterior to the posterior gluteal line of the ilium, on the dorsal surface of the sacrum and coccyx, and on the sacrotuberous ligament. It then slopes inferolateral at a 45-degree angle from the pelvis to the buttocks, where fibers from its superior part, alongside superficial fibers from its inferior part, insert into the iliotibial tract, a longitudinal fibrous reinforcement of the fascia lata, which crosses the knee and attaches to the anterolateral tubercle of the tibia. Additionally, some of the deep fibers on the inferior part of the muscle attach to the gluteal tuberosity of the femur. The gluteus maximus is supplied by the inferior gluteal nerve from roots L5, S1, and S2, and by both the inferior and superior gluteal arteries. When it comes to actions, it steadies, extends, and laterally rotates the thigh. It helps with getting up from a sitting position, and when the distal attachment of the gluteus maximus is fixed, the muscle extends the trunk on the lower limb. It also helps us straighten from bending positions, like when walking upstairs or hills. Finally, since the gluteus maximus inserts onto the iliotibial tract, it also assists in stabilizing the extended knee. Oh, and while we're at it, we should mention that the gluteus maximus is separated from adjacent structures by the gluteal bursas. Bursas are membranous sacs lined by a synovial membrane containing a capillary layer of slippery fluid resembling egg whites that lubricates overlying structures to counteract friction and permit free movement. The fluid is a lubricant, which is why bursas are typically located in areas subject to friction, like where the iliotibial tract crosses the greater trochanter, to reduce friction and permit free movement. There are three bursas associated with the gluteus maximus. First is the trochanteric bursa, which is the largest of the three, and it separates the superior fibers of the gluteus maximus from the greater trochanter. Second, the ischial bursa separates the inferior part of the gluteus maximus from the ischial tuberosity. However, this one is often absent. And third, the gluteofemoral bursa separates the iliotibial tract from the superior part of the proximal attachment of the vastus lateralis. Now, deep to the gluteus maximus are the gluteus medius and minimus. These two muscles are both fan-shaped, and they both originate on the external surface of the ilium. Specifically, gluteus minimus originates between the anterior and inferior gluteal lines of the surface, and it inserts on the anterior surface of the greater trochanter of the femur. The gluteus medius, on the other hand, is between the posterior and anterior gluteal lines, and inserts on the lateral surface of the greater trochanter. The two gluteae also share the same nerve supply, namely the superior gluteal nerve, and the same blood supply, through the superior gluteal artery. And they have the same actions, which is abducting, stabilizing, and rotating the thigh medially. These muscles are also important for walking and standing, as they keep the pelvis level during walking when the ipsilateral leg is planted, and prevent sagging of the unsupported contralateral side during swing phase or standing. And the final muscle of the superficial layer is the tensor fascia lata, which is a spindle-shaped muscle approximately 15 centimeters long that's enclosed between the two layers of fascia lata. It originates on the anterior superior iliac spine and on the anterior part of the iliac crest. From this point, it descends on the superficial and anterior part of the gluteus maximus, with which it shares a common distal attachment, the iliotibial tract, via which it inserts on the lateral condyle of the tibia. However, unlike the gluteus maximus, the tensor fascia lata is served by the superior gluteal nerve and artery. When it comes to movement, it has the same actions as the gluteus minimus and medius, which is abducting, stabilizing, and rotating the thigh medially, as well as keeping the pelvis stable when only one leg is weight-bearing. It also serves as a hip flexor due to its anterior location, and, as its name indicates, it tenses the fascia lata and iliotibial tract. And now, let's have a small break and test you out to see if you can remember the origins and insertions of the superficial muscles of this region. Let's move on to the deep layer, which consists of 5 muscles covered by the inferior half of the gluteus maximus: the piriformis, obturator internus, superior and inferior gemelli, and quadratus femoris. Actually, there's also a 6th muscle called obturator externus, which is physically part of the adductor compartment of the thigh, but it is functionally related to this region as it is a lateral rotator of the thigh. So think of it as an honorary member of the gluteal region. Okay, first, the piriformis is pear-shaped, hence its name, and it's located partly on the posterior wall of the lesser pelvis and partly posterior to the hip joint. The piriformis originates on the anterior surface of the sacrum and the sacrotuberous ligament, and then it leaves the pelvis through the greater sciatic foramen and inserts on the superior border of the greater trochanter. The muscle is directly supplied by branches from the anterior rami of S1 and S2 spinal nerves. The piriformis, along with the obturator internus and the superior and inferior gemelli, are responsible for laterally rotating the extended thigh, abducting the flexed thigh, and steadying the femoral head in the acetabulum. The next 3 muscles, the obturator internus and the superior and inferior gemelli, also known as the twins, form a 3-headed muscle called the triceps coxae, or triceps of the hip. The triceps coxae occupies the gap between the piriformis and the quadratus femoris. Regarding proximal attachments, the obturator internus originates on the pelvic surface of the obturator membrane and surrounding bones, the superior gemellus on the ischial spine, and the inferior gemellus on the ischial tuberosity. All 3 muscles have the same insertion point on the medial surface of the greater trochanter of the femur. The obturator internus and superior gemellus are both supplied by the nerve to the obturator internus, while the inferior gemellus and the muscle underneath it, quadratus femoris, are supplied by the nerve to the quadratus femoris. Speaking of which, the quadratus femoris is a short, flat, quadrangular muscle situated just beneath the obturator internus and the twin gemelli. True to its name, the quadratus femoris is a rectangular muscle that originates on the lateral border of the ischial tuberosity. The muscle has a horizontal trajectory as well, and it goes on to insert on the quadrate tubercle on the intertrochanteric crest of the femur. As mentioned, it is supplied by the nerve to quadratus femoris, and it's responsible for rotating the thigh laterally and steadying the femoral head in the acetabulum. Time for a break and put those brain muscles to rest. Meanwhile, to reward yourself, try and recognize the origins and insertions of the deep muscles of the gluteal region. Now, let's switch gears and look at the muscles of the posterior thigh, collectively known as the hamstrings. This group consists of the semitendinosus, the semimembranosus, and biceps femoris. Generally speaking, the hamstrings originate on the ischial tuberosity. They project downward to insert on the bones of the leg and cross both the hip and knee joint to extend the hip and flex the knee. However, it's important to note that the biceps femoris muscle has 2 heads, the long head and the short head. Only the long head is considered a hamstring muscle, as the short head does not have the same features as the other 3 muscles. The semitendinosus, called that because half the muscle is represented by a muscular belly and half by its cord-like tendon, originates on the ischial tuberosity and inserts on the medial surface of the superior part of the tibia. The semimembranosus, named that because of its membrane-like origin, also originates on the ischial tuberosity and has a direct insertion on the posterior aspect of the medial tibial condyle. It also blends with the popliteal fascia and has reflected attachment which forms the oblique popliteal ligament. The insertion onto the medial tibia of the semitendinosus, along with the sartorius and gracilis muscle, is collectively known as the pes anserinus, which means goosefoot. Alright, now innervation to the semitendinosus and semimembranosus is provided by the tibial division of the sciatic nerve from nerve roots L5, S1, and S2, whereas blood is supplied by the profunda femoris and gluteal arteries. These two muscles extend the thigh, flex the leg, and rotate it medially when the knee is flexed. And when both the thigh and leg are flexed, they can extend the trunk. The biceps femoris has a long head and a short head. The long head originates on the ischial tuberosity, whereas the short head originates on the linea aspera and lateral supracondylar line of the femur. These two heads merge in the inferior part of the thigh to form a tendon that inserts on the lateral surface of the head of the fibula, where it's split by the fibular collateral ligament of the knee. The long head of the biceps is supplied by the tibial division of the sciatic nerve, while its short head is supplied by the common fibular division of the sciatic nerve, with both being from L5, S1, and S2, and the profunda femoris artery. The biceps flexes the leg and rotates it laterally when the knee is flexed, and additionally, it extends the thigh. That wasn't too thiring, now was it? Now, before we wrap up, let's try to recall the origins and insertions of the hamstrings. Alright, as a quick recap, the sacrotuberous ligament and the sacrospinous ligament convert the greater and lesser sciatic notches into greater and lesser sciatic foramina. The greater sciatic foramen allows for the passage of structures entering and exiting the pelvis, where the lesser sciatic foramen allows for the structures entering and exiting the perineum. The superficial muscles consist of the gluteus maximus, gluteus medius, gluteus minimus, and the tensor fasciolata. The deep muscular layer of the gluteal region consists of the piriformis, triceps coxae, which is formed by the obturator internus and the two gemelli, and the quadratus femoris. The posterior thigh muscles are the three hamstrings, namely the semitendinosus, semimembranosus, and long head of biceps femoris. The gluteal region and posterior thigh contain an abundance of large and small muscles, and coursing through these muscles is a vast network of nerves and vessels. These nerves mainly originate from the lumbosacral plexus, whereas the vascular supply derives either directly or indirectly from the internal iliac arteries. Okay, so let's now move on to nerves of the gluteal region and posterior thigh. Most nerves of the lower limb arise from the lumbosacral plexus, a network of nerves derived from the roots of lumbar and sacral spinal nerves that branch out to form the nerves of the lower limb. However, out of all the resulting nerves, the gluteal region and posterior thigh is only supplied by the cluneal nerves, superior and inferior gluteal nerves, the sciatic and pudendal nerves, the posterior cutaneous nerve of the thigh, and nerves to quadratus femoris and obturator internus. Let's start off with the cluneal nerves, which innervates the skin of the gluteal region. The superior cluneal nerves arise from L1 to L3 and supply the skin of the superior buttock. The middle cluneal nerve arises from S1 to S3 and supplies skin over the sacrum and adjacent area of the buttocks. And finally, the inferior cluneal nerve is a branch of the posterior cutaneous nerve of the thigh, from S2 to S3, and supplies skin over the inferior half of the buttocks as far as the greater trochanter. Next, there's the superior gluteal nerve, which is formed by the L4, L5, and S1 nerve roots. The nerve courses laterally between the gluteus medius and minimus along the deep branch of the superior gluteal artery, and it exits the pelvis through the greater sciatic foramen above the piriformis muscle. It then goes on to innervate the gluteus medius, the gluteus minimus, and the tensor fascia lata. This nerve doesn't have any sensory function. The inferior gluteal nerve is formed by L5, S1, and S2 nerve roots, and, much like its brother, it leaves the pelvis through the greater sciatic foramen, but inferior to the piriformis. It's also accompanied by multiple branches of the inferior gluteal artery and vein along its trajectory. The inferior gluteal nerve ultimately divides into several branches, which provide motor innervation to the overlying gluteus maximus, but no sensory supply. Then, there's the sciatic and pudendal nerves, both of which are terminal branches of the sacral plexus. The sciatic nerve is the largest nerve in the body, and it's formed by the roots of L4, L5, S1, S2, and S3 spinal nerves. Interestingly, the sciatic nerve is really two nerves, the tibial nerve and the common fibular nerve, which are loosely bound together in the same connective tissue sheath. Regardless, the roots of the aforementioned spinal nerves converge at the inferior border of the piriformis to form the sciatic nerve, which enters the gluteal region underneath the piriformis and is the most lateral structure through the greater sciatic foramen. When it reaches the apex of the popliteal fossa, the nerve separates into the tibial and common fibular nerves, which are also considered its main branches. Now, the sciatic nerve supplies no structure in the gluteal region, but it does supply the posterior thigh muscles, all leg and foot muscles, and the skin of most of the leg and foot. It also supplies the articular branches to all joints of the lower limb. As a side note, it's important to note that the sciatic nerve can have anatomical variations. As said before, it typically leaves the greater sciatic foramen below the piriformis. However, in up to 12% of individuals, the sciatic nerve divides before exiting the greater sciatic foramen, and its common fibular division pierces the piriformis as it leaves, compared to the tibial division, which still exits below the piriformis. In a very small 0.5% of individuals, the common fibular division will actually leave the greater sciatic foramen above the piriformis, and the tibial division still leaves below the piriformis. Now, medial to the sciatic nerve, there's the pudendal nerve, which originates from the S2 to S4 nerve roots and is the most medial structure to exit the pelvis through the greater sciatic foramen. It descends inferior to the piriformis, posterolateral to the sacrospinous ligament, and enters the perineum through the lesser sciatic foramen. It travels through the pudendal canal, an anatomical structure in the pelvis through which the internal pudendal artery, internal pudendal vein, and pudendal nerve pass. Within the canal, the nerve divides into the inferior rectal nerve at the posterior end of the canal, and two terminal branches, the dorsal nerve of penis or clitoris, and the perineal nerve. Now, while the pudendal nerve is the main nerve of the perineum, it supplies no structures in the gluteal region or posterior thigh. Next up, the posterior cutaneous nerve of the thigh is formed by the S1, S2, and S3 nerve roots. It lies upon the psoas muscle, from where it travels laterally into the greater sciatic foramen, through which it exits the pelvis below the piriformis muscle. Within the gluteal region, the nerve is initially situated beneath the gluteus maximus muscle. Then it descends superficial to the long head of the biceps femoris in the posterior thigh, where it is deep to the fascia lata. However, it soon pierces the fascia in the popliteal fossa, and it terminates with twigs joining the sural nerve. Now, this nerve gives off three important branches. One of them is the inferior cluneal nerve, as we said earlier. Then there's a cutaneous branch, which supplies the skin of the popliteal fossa. And finally, the third branch is the perineal branch, which supplies the posterior part of the scrotum or labia majora. And finally, the nerves to quadratus femoris and obturator internus are both branches arising from the pelvic surface of the plexus. The nerve to the quadratus femoris is formed by the anterior divisions of L4, L5, and S1, and it leaves the pelvis inferior to the piriformis and deep to the sciatic nerve. It supplies an articular branch to the hip joint and innervates the inferior gemellus and quadratus femoris muscles. On the other hand, the nerve to the obturator internus arises from the anterior divisions of the anterior rami from the L5, S1, and S2, and leaves the greater sciatic foramen inferior to the piriformis to parallel the course of the pudendal nerve. As it passes around the base of the ischial spine, the nerve supplies the superior gemellus, and after entering the perineum via the lesser sciatic foramen, it supplies the obturator internus muscle. Before we move on to blood vessels, let's try and recall the main nerves of the sacral plexus. Okay, switching over to arteries, the gluteal region is supplied or transversed by major branches of the internal iliac artery, namely the superior gluteal artery, inferior gluteal artery, and internal pudendal artery. First, the superior gluteal artery is the largest of the branches, and, from its origin, passes posteriorly between the lumbosacral trunk and the S1 nerve. This artery leaves the pelvis through the greater sciatic foramen, superior to the piriformis, and divides immediately into superficial and deep branches. The superficial branch supplies the gluteus maximus and skin over the proximal attachment of this muscle. The deep branch supplies the gluteus medius, gluteus minimus, and tensor fasciae latae. Ultimately, the superior gluteal artery goes on and anastomoses with the inferior gluteal and medial circumflex femoral arteries. Second, the inferior gluteal artery passes posteriorly through the parietal pelvic fascia between the S1 and S2 nerves. It then leaves the pelvis through the greater sciatic foramen, inferior to the piriformis, only to enter the gluteal region deep to the gluteus maximus, and to descend medial to the sciatic nerve. In the gluteal region, the inferior gluteal artery supplies the gluteus maximus, obturator internus, quadratus femoris, and superior parts of the hamstrings. It also anastomoses with its sister, the superior gluteal artery, and it sometimes participates in the cruciate anastomosis of the thigh. This fancy name structure is a union of the inferior gluteal artery, the lateral and medial circumflex femoral arteries, and the first perforating artery of the profunda femoris artery in the upper thigh, which supplies most of the structures of the proximal posterior thigh. And third, the internal pudendal artery lies anterior to the inferior gluteal artery. Its course parallels that of the pudendal nerve, entering the gluteal region through the greater sciatic foramen inferior to the piriformis, which it leaves immediately by crossing the ischial spine only to reach the perineum through the lesser sciatic foramen. Like the pudendal nerve, it supplies the skin, external genitalia, and muscles in the perineal region. It does not supply any structures in the gluteal region of posterior thigh. Moving on, the gluteal region also houses the 4 perforating arteries of the profunda femoris artery. 3 of the arteries originate in the anterior compartment of the thigh, whereas the 4th is actually the terminal branch of the profunda femoris artery itself. Now, the perforating arteries are large vessels with an intercompartmental course. This means that from their anterior origin, they perforate the aponeurotic portion of the distal attachment of the adductor magnus to enter the posterior compartment. Here, they typically give rise to muscular branches to the hamstrings and anastomotic branches that ascend or descend to unite with those arising from the other perforating arteries, or the inferior gluteal and popliteal artery. When it comes to the posterior compartment of the thigh, this part of the thigh has no major artery exclusive to the compartment as it receives blood from multiple sources: inferior gluteal, medial circumflex femoral, perforating branches from the profunda femoris, and popliteal arteries. These arteries form a continuous anastomotic arterial chain that extends from the gluteal to popliteal regions. Moving on, the veins of the gluteal region and posterior thigh are mostly represented by superior and inferior gluteal veins, which are tributaries to the internal iliac veins. These accompany the arteries with the same names through the greater sciatic foramen, superior and inferior to the piriformis respectively, and drain the buttock and upper thigh. Then there's also the internal pudendal veins, which accompany the internal pudendal arteries. The internal pudendal veins ultimately join to form a single vein that enters the internal iliac vein, and they drain the external genitalia, or pudendum. And finally, there are also perforating veins which accompany the arteries of the same name to drain blood from the posterior compartment of the thigh into the profunda femoris vein. The perforating veins, like the arteries, usually communicate inferiorly with the popliteal vein and superiorly with the inferior gluteal vein. When it comes to lymphatic drainage, lymph from the deep tissues of the buttocks follows the gluteal vessels to the superior and inferior gluteal lymph nodes, and from them to the internal, external, and common iliac lymph nodes, and from them to the lateral lumbar or aortic lymph nodes. Lymph from the superficial tissues of the gluteal region passes initially to the superficial inguinal nodes, which also receive lymph from the thigh. From the superficial inguinal nodes, lymph passes via efferent lymph vessels to the external and common iliac nodes. Lymph continues on to the right and left lumbar lymph nodes, draining via lumbar lymphatic trunks to the cisterna chyli and thoracic duct. Now another test. Can you label the 14 structures that come out of the greater sciatic foramen? Here's a hint. One of them is a muscle. Alright, as a quick recap, cutaneous innervation of the gluteal region and posterior thigh is accounted for by the superior cluneal nerves, which arises from the posterior primary rami of the first 3 lumbar nerves, and supplies the skin on the superior 2/3 of the buttock. Next, we have the nerves coming from the sacral plexus, such as the middle cluneal nerve, which originates as a lateral cutaneous branch of the posterior rami of S1 to S3, and it supplies the skin over the sacrum and adjacent area of the buttocks. There's also the inferior cluneal nerve, arising from the posterior cutaneous nerve of the thigh, to supply the skin of the inferior part of the buttocks as far as the greater trochanter. The superior gluteal nerve, formed by the L4, L5, and S1 nerve roots, supplies the gluteus medius, minimus, and the tensor fasciae latae. The inferior gluteal nerve is formed by the L5, S1, and S2 nerve roots, and it provides motor innervation to the overlying gluteus maximus. The sciatic nerve is formed by the roots of L4, L5, S1, S2, and S3 spinal nerves, and it supplies the posterior thigh muscles, all leg and foot muscles, the skin of most of the leg and foot, and it can have anatomical variations. The pudendal nerve originates from the S2 to S4 nerve, and it supplies the perineum. The posterior cutaneous nerve of the thigh, formed by S1, 2, and 3 nerve roots, gives off branches such as the inferior cluneal nerve, which we mentioned, the cutaneous branch, which supplies the skin of the popliteal fossa, and the perineal branch, which supplies the posterior part of the scrotum or labia majora. The nerve to quadratus femoris is formed by the anterior divisions of L4, L5, and S1, and it innervates the inferior gemellus and quadratus femoris muscles. The nerve to the obturator internus arises from L5, S1, and S2, and it supplies the superior gemellus and the obturator internus muscle. The arteries of the gluteal region are all branches of the internal iliac artery, namely the superior gluteal artery, inferior gluteal artery, and internal pudendal artery. The posterior thigh receives blood from multiple sources, including the inferior gluteal, medial circumflex femoral, perforating branches of the profunda femoris, and popliteal artery. The veins of the gluteal region and posterior thigh are mostly represented by superior and inferior gluteal veins, the internal pudendal veins, and by perforating veins. Finally, Lymphatic vessels from the deep tissues of the buttocks follow the gluteal vessels to the superior and inferior gluteal lymph nodes, and from them to the internal, external, and common iliac lymph nodes, and from them to the lateral lumbar lymph nodes. Lymph from the superficial tissues of the gluteal region enters the superficial inguinal lymph nodes, which also receive lymph from the thigh.